Director of the Office of Child and Family Services at the Department of Behavioral Health and Developmental Services. I would like to welcome you all to Unpacking the Multifaceted Complexities of Eating Disorders Symposium. You're the frontline staff, clinicians, and administrators who work every day to care for and improve the lives of our young people and their families. So thank you. Disordered eating related to stress, poor nutritional habits, and food fads are relatively common problems for youth. Weight perception transitions and body image in adolescence can lead to disordered eating behaviors, with 50% of teenage girls and 30% of teenage boys using unhealthy weight control behaviors. By 17 years old, 89% of adolescent girls have dieted to obtain an ideal body shape. We know that while 30 million people in the United States have an eating disorder, 95% of those are between the ages of 12 and 25. Moreover, 50% of adolescents with an eating disorder have a co-occurring depression or anxiety disorder. It cannot be overstated that diverse communities, such as the LGBTQ+ community and Black, Indigenous, and people of color, as well as those from lower socioeconomic statuses or backgrounds, experience long-standing disparities in healthcare access, which produces disproportionate outcomes in the identification of diagnostic practices and treatment regarding eating disorders. 60% of LGBTQ youth and young adults have self-reported engaging in at least one disordered eating behavior in 2019 alone, with the number drastically increasing during the COVID-19 pandemic. And Black adolescents are 50% more likely than their white counterparts to present with bulimic behaviors. And members of the Black, Indigenous, or people of color communities are less likely to be asked about their experiences with disordered eating and half as likely to be diagnosed with an eating disorder or receive treatment. We're well aware of the role that the pandemic has played in shaping mental health in our youth. Additionally, according to the National Eating Disorders Association, their helpline experienced a 40% volume increase beginning in March 2020, with 35% of callers between the ages of 13 and 17. Furthermore, and nationally, inpatient admissions for youth seeking treatment for eating disorders rose to 7% a month on average during the first year of the pandemic. And while eating disorders have the highest risk of death of any mental illness, we know that 700,000 or 9% of Virginians will experience some eating disorder in their lifetime, resulting in $1.7 billion in economic costs annually. Data supports that our hospitals across Virginia have seen an average of 1,400 ER visits and 600 hospitalizations annually resulting from disordered eating. Bringing relevant training such as this to the field is one way to raise awareness and increase our efforts around the quality of care provided across the state, and just one piece of that really complex puzzle. Research shows that early identification and intervention are key elements to successful treatment of eating disorders. And as such, when youth can receive the help they need, they fare better at home, in school, and we can keep them safely in their communities. Beyond this vital area of focus, I wanted to update you on a few things that are happening in our office that correspond with this. So we're also working to address access and consistency of services across the behavioral health continuum, specifically looking at an adolescent substance use continuum of care. We're also looking at expansion of school-based services for mental health and substance use. And of note, we partnered with Chesterfield Mental Health in the past couple of years for the first ever recovery high school in Virginia for substance use disorders, and we hope to soon expand this to other regions of the state. We continue to push forward evidence-based practices for treatment and recovery, and over the past couple of years, we've partnered with pediatricians and family practice doctors and nurse practitioners from across the state to enhance the training they receive on youth behavioral health issues, and to also provide them with access to consultations with child and adolescent psychiatrists, licensed mental health professionals, and care navigators. All of this to assist doctors and the families that they're treating to receive the appropriate treatment earlier and through whatever door that family walks through. And so with that in mind, we've chosen to present this symposium to assist in cultivating the intersectional approach and the examination of eating disorders through an equity-informed framework. The Unpacking of Multifaceted Complexities of Eating Disorder Symposium is comprised of subject matter experts that you're really going to enjoy, that will be delivering the most up-to-date research and resources regarding youth with eating disorders. We hope you find this training helpful and enriching and a source of practical strategies and solutions. And as always, we will continue to partner together to help our young people and their families have the best opportunities for success and abundance in their lives. Thank you.
Good morning. I'm Eo McCoy with the Office of Child and Family Services. Today, I will be introducing Dr. Sarah Groff-Stevens. Sarah Groff-Stevens is a licensed clinical social worker who provides outpatient behavioral health treatment at UVA Children's at the Teen and Young Adult Health Center. She specializes in working with adolescents and young adults with eating disorders and accompanying mental health disorders. Originally from Jacksonville, Florida, Dr. Stevens received her undergraduate degree from the University of North Florida and her master's and doctorate degrees in social work from Florida State University. She completed her specialized training in eating disorders at Providence St. Vincent Medical Center in Portland, Oregon, and their intensive outpatient and partial hospitalization programs for adolescent and adult eating disorders. Her research has been focused on factors that cause and maintain eating disorders. Thank you, Dr. Groff-Stevens, for being here. Now I'll turn it over to you.
All right, I'm gonna share my screen. Make this big. All right, can everyone hear me okay? Take that as a yes. Thank you. Okay, great. Thank you so much for that introduction. I'm really excited to be here today and be talking about these important topics. My clinical career actually started off as a victim advocate at Florida State University, where I supported students through various traumas and provided counseling services. I saw a number of individuals with eating disorders and body image concerns in that work, especially related to victims and survivors of sexual violence. And this prompted me to look at this connection in my research during grad school. And then after obtaining my PhD, I went on to further my clinical career, where again, the theme of trauma and eating disorders was present. So this topic is very near and dear to my heart, and I'm very passionate about it. As we mentioned, we'll have about 20 minutes of Q&A at the end. So please put questions in the chat, things that you want to know afterwards. So we have a lot to cover today. We want to talk about the connection between trauma and eating disorders, talk about treatment considerations for someone with PTSD and an eating disorder, look at the connection with negative body image and eating disorders, talk about how negative body image develops, and then we're going to spend some time talking about interventions for negative body image, talk about prevention efforts, and also be aware of size diversity and health at every size, what we call HAES. So just briefly, here are the eating disorders that are recognized by the latest version of the DSM, the DSM-5. We have anorexia nervosa, of which there's two subtypes, the restricting type of anorexia and the binge purge subtype. We have bulimia nervosa, avoidant restrictive food intake disorder, or ARFID, binge eating disorder, other specified feeding or eating disorders, of which there are many, atypical anorexia, bulimia nervosa of low frequency, purging disorder, binge eating disorder of low frequency, and night eating syndrome, and also unspecified eating disorder. So you'll notice today that I'm not going to spend much time talking about specific eating disorders. The reason for this is that I operate from a transdiagnostic approach. The transdiagnostic view was created by Fairburn and colleagues, and it's based on the observation that the main maintaining processes of eating disorders are likely to be largely the same across the different eating disorder diagnoses. And there are some research considerations for doing this. Specific behaviors and weight status often determine which diagnosis a person has, which can and does change over time, or often does. diagnostic crossover is very high in eating disorder patients, and the longer one struggles with an eating disorder, the higher the likelihood is that they will transition from one diagnosis to another, or from a subthreshold diagnosis, such as bulimia nervosa of low frequency, to the full disorder. There's also specific overlap of behaviors. For example, the binge eating and purging behaviors can be seen in anorexia nervosa and the binge purge subtype, and also bulimia nervosa. And there's research that argues that the behaviors, for example, the purging behaviors, can be more meaningful than the diagnoses. So today I'm going to talk about eating disorders broadly, and we'll also discuss some specific eating disorder behaviors, especially as I'm talking about their relationship with trauma. There's also some clinical considerations to operating from this viewpoint. When working with individuals, I often just discuss the eating disorder. I do this to break down any potential hierarchy or status one diagnosis may have over another, and try and reduce personal identification with the eating disorder. Mortimer in 2019 did a qualitative study of ex-patients who had experienced diagnostic crossover, or the transition between two or more eating disorder diagnoses. And the study found that in the minds of participants, the different diagnostic labels were associated with various good or bad character traits. And this contributed to the belief in a diagnostic hierarchy, whereby individuals diagnosed with anorexia were viewed as morally better than those diagnosed with bulimia nervosa or binge eating disorder. So consequently, diagnostic crossover from a quote better to a quote worse eating disorder was often experienced as a shameful moral failing, and a new diagnosis impacted the individual's sense of self-identity. So talking about the eating disorder helps reduce some of that. CBTE stands for Enhanced Cognitive Behavioral Theory of Eating Disorder. It's derived from the transdiagnostic view of the eating disorders. And in this model, the overevaluation of shape and weight and their control is the central maintenance to all eating disorders. This overvaluation of shape and weight results in dietary restraint and restriction, preoccupation with thoughts about food and eating weight and shape, repeated checking of body shape and weight or its avoidance, and the engaging in extreme methods of weight control, such as compensatory behaviors, which can include self-induced vomiting, laxative misuse, severe restriction, or excessive exercise. And if binge eating occurs, it is largely the result of attempts to adhere to multiple extreme and highly specific dietary rules. And the repeated breaking of these rules is almost inevitable. So this in turn maintains the core psychopathology by intensifying patients' concerns about their ability to control their eating shape and weight. It also encourages more dietary restraint. So here's a breakdown of these cycles a little bit. So starting off with the binge restrict cycle, we have somebody who's restricting, they're limiting what or how much they eat. They may be engaging in diets or detoxes or calorie counting, which leads to intense cravings, constantly thinking about foods, particularly off-limits foods or foods that they're not allowing themselves to eat. And this can lead into a binge, giving in to cravings and eating in an out-of-control way. And I'd like to point out that this could be both an objective binge or also a subjective binge, where it may not be that much food, but for the person, it feels out of control because it's more than what they intended. And then also shame, feeling like they must gain control of food and their body, and so they return back to their restriction patterns. The binge purge cycle is very similar, where you have the strict dieting, kind of these slips or a difficult situation arises where they eat things outside of what they're comfortable with. Binge eating is triggered. They engage in purging behaviors to avoid weight gains, feeling of that shame and self-hatred, which returns back to strict dieting. So before I get into talking about the trauma piece, I want to discuss that what causes eating disorders is very complicated. There is not one thing that causes an eating disorder. We know that it's a complex interplay of biological, psychological, and social or environmental factors that come together as a perfect storm storm for the development and maintenance of an eating disorder. And today we're going to focus a lot on the environmental or social factors of eating disorders, at least in this talk, and how individuals respond to environmental or social factors is of course related to psychological and biological factors, hence the bidirectionality of the circles above. Okay, so the trauma and eating disorders connections. Trauma is widely defined as a deeply distressing or disturbing experience. Traumatic events have been linked to eating pathology. High rates of trauma history are found among those with eating disorders, and estimates range from 37 to 100% depending on the samples. The greatest evidence links interpersonal forms of trauma with eating disorders, but there is also evidence of non-interpersonal forms of trauma with eating disorders, such as car accidents, combat, and serious illness. The two types of trauma that I'm going to go into some depth with today is sexual violence and child abuse. Of course, which we have child sexual abuse, which overlaps with sexual violence. So sexual violence is defined broadly as sexual activity when consent is not obtained or freely given. The perpetrator of sexual violence is usually someone the survivor knows, such as a friend, current or former intimate partner, coworker, neighbor, or family member. We know, unfortunately, that sexual violence is very common. It affects millions of people each year in the United States. Researchers know that the numbers underestimate this problem because many cases are unreported. Survivors may be ashamed, embarrassed, or afraid to tell police, family, or friends about the violence. And victims may also keep quiet because they've been threatened with further harm if they tell anyone, or they do not think anyone will help them. Some recent stats from the CDC show that over half of women and about 1 in 3 men have experienced sexual violence involving physical contact during their lifetimes. 1 in 4 women and about 1 in 26 men have experienced completed or attempted rape. And 1 in 3 women and about 1 in 9 men experience sexual harassment in a public place. We also know that sexual violence starts early. More than 4 in 5 female rape survivors report that they were first raped before age 25, and almost half were first raped before the age of 18. I recently read that 1 in 10 girls is catcalled before her 11th birthday. And some groups are disproportionately affected: women, racial and ethnic minority groups, and LGBTQ+ individuals. And this relationship is unfortunately understudied in national surveys because they report on the binary of male and female, which limits knowledge of transgender sexual violence. Researchers in 2017 found that LGBTQ+ college students reported significantly higher rates of every form of sexual violence. And here's a study that breaks this down a bit. They looked at a large sample of high schoolers from 9th to 12th grade that looked at the prevalence of victimizations among LGBTQ and heterosexual males and females. And when odds ratios are compared across the intersections of gender and sexual orientation, what is most evident is that LGBTQ females have the highest odds of experiencing dating and sexual violence victimization than any other group. And not only are they over 4 times more likely to experience these type of violence, but odds ratios are marginally higher than any other group. What's also unique is that LGBTQ males had significantly higher odds of experiencing dating violence victimization and were equally as likely to experience sexual violence victimization than heterosexual females. So this is suggesting that there are clear gendered and sexualized dynamics at play. I'm also highlighting these differences because research is suggesting that LGBTQ+ individuals are also at heightened risk of engaging in eating disorder behaviors. Women with histories of sexual violence have increased likelihood of eating problems or eating disorders. And there's a lot of research suggesting that purging behaviors seem to be more indicative of sexual violence than restricting behaviors. Research that I did with my colleagues suggested that the more severe the form of sexual violence, the greater the likelihood will be that an individual engages in purging behaviors. And this relationship between purging and sexual violence is also seen in males. For my dissertation, I did a secondary analysis of a very large sample of college students where I looked at the different degrees of sexual violence and their relationship to different behaviors, one of which was purging behaviors. And sexual violence was defined as mild, moderate, and severe, where mild was unwanted sexual touching, moderate was attempted rape, and severe was completed rape. And here are my results for purging and sexual violence. There were significant interactions for being male and experiencing sexual violence for the mild and severe groups. And when we examined what's called the marginal effects of men and women, it revealed that although men had significantly lower baseline odds than women, the odds of purging for men and women who experienced severe sexual violence were almost identical. It was 0.114 for women compared to 0.109 for men. And so the gender differences at baseline are consistent with previous research suggesting that men have lower rates of eating disorder behavior than women. But interestingly, research suggests that men with eating disorders are less likely to women to engage in typical compensatory behaviors such as purging. So this finding that men who experienced severe sexual violence had odds of reported purging that was nearly identical to females is intriguing and lends more support to the idea that purging is uniquely associated with sexual violence. I also just want to put a reminder again that purging behaviors can be seen in both anorexia nervosa and bulimia nervosa. And it's also a behavior that individuals may be hesitant to disclose because of shame. So shifting gears to talk about child abuse. This is defined as physical abuse, sexual abuse, emotional abuse, and neglect of a child under the age of 18 by a parent, caregiver, or another person in a custodial role. Child abuse and neglect are common. At least 1 in 7 children have experienced child abuse or neglect in the past year in the United States. This is likely an underestimate because many cases are unreported. Children living in poverty experience more abuse and neglect. Experiencing poverty can place a lot of stress on families, which may increase the risk for child abuse and neglect. Rates of child abuse and neglect are 5 times higher for children and families with a low socioeconomic status. We also know that individuals with low SES are less likely to be identified for eating disorders due to historically incorrect and problematic beliefs and messaging that eating disorders only affect thin, privileged white females. And children who are abused or neglected are at an increased risk for experiencing future violence, victimization, and perpetration. Childhood abuse is reported by a significant proportion of people with eating disorders, and childhood maltreatment has largely been recognized as an important non-specific risk factor for eating disorders. Compared to both healthy subjects and people suffering from other psychiatric disorders, people with eating disorders report a higher prevalence of childhood maltreatment, regardless of its nature and of the type of eating disorder. Although the association between childhood maltreatment and eating disorders seems to be less pronounced for subjects with the restricting type of anorexia nervosa, which does have more correlation with childhood anxiety and OCD. In addition, maltreated individuals with eating disorders were seen to be characterized by more severe clinical presentation in terms of earlier age at onset, symptom severity, psychiatric comorbidities, and also suicidal or self-harm behaviors. And among the different types of childhood maltreatment, emotional abuse has shown a direct connection with eating disorder symptoms, while sexual and physical abuse have been associating to eating disorder psychopathology through the mediation of one or more psychiatric comorbidities. So I want to just talk about some models to discuss why trauma and eating disorders are connected. The stress and coping theory was developed by Lazarus and Folkman. Briefly, there's a stressful event and there's adjustment to the event, and that is mediated by the coping process. And coping responses are dependent on both the person and the environment in a specific context. So Tobin and colleagues explains the coping processes as approach strategies, where they're focused on the stressful, things like planful problem solving or reframing thoughts, or avoidance strategies, which are focused on avoiding the stressors, things like withdrawing from others or making the self feel better by drinking, harming oneself, distraction, fantasy, or eating disorder behaviors. Littleton and colleagues found that individuals who experienced trauma had a heavy reliance on both types of avoidance strategies to cope with trauma, and further, that these avoidance strategies were associated with more psychological distress. The model above was developed by Mitchell and colleagues. It took that CBTE model of eating disorders that I showed you at the beginning of this presentation, and it describes the mechanisms that an eating disorder, that a person with an eating disorder and PTSD, and the hypothesized functional linkages between the symptoms. So in this model, it's been suggested that the binge purge behaviors are associated with impulsivity and could be mechanisms to avoid awareness of trauma or reduce negative affect. Again, purging in particular has been discussed as having a functional role in regulating emotions and cognitions through distracting, blocking, and or self-punishment. So the function of these eating disorder behaviors, there may be some mediating roles, things for dissociations, difficulties in regulating emotions, self-criticism, and body dissatisfaction. The development of eating disorder symptoms and behaviors may play a functional and adaptive role in terms of managing PTSD and other trauma-related symptoms, such as the dissociation, depression, and other forms of anxiety. Binging, purging, restricting, excessive exercising, and or abusing substances may impair cognitive processing and facilitate avoidance of trauma-related memories, affects, behaviors, cognitions, and their cues. This is what's called the self-medication hypothesis. I have a whack-a-mole image up here because a lot of patients describe this phenomenon where someone gets containment of one behavior, such as purging or restricting, and then self-harming may be the bigger problem that pops up. And they make progress with reducing self-harm, and then the substance use increases, and that mole pops up. And what we talk about often is that the trauma is the underlying factor, and the individual's using a lot of different behaviors or to self-medicate or cope with managing the PTSD or other trauma-related symptoms. We're going to talk a little bit about how trauma impacts body image. Many individuals after trauma like sexual violence experience body shame, body blame, a desire to punish the body. They may not want attention, or they may not want to be attractive. They may wear baggy clothes to hide their body, kind of this idea of seeking safety. Or the opposite, individuals may want attention or wanting to be very attractive, wearing revealing clothing and acting more sexual to regain a sense of control. I really like these quotes to describe some of what's happening. So because the body has been treated as an object by the perpetrator and the boundaries of the self have been damaged and violated, there is often a dissociation and separation from the body itself. Part of this is denial. It did not happen to me, but to this body. Part of this is the psychosocial coping mechanism to decrease bodily pain. And part of that is pure rejection. The body is seen as something shameful, disgusting, and dirtying for, quote, letting the assault happen. The focus of the survivor is on molding, punishing, controlling, and treating the body as something external, an object. And radically different coping mechanism strategies fall under this category, from comfort food to binge and purge behaviors, self-harm, and elective cosmetic surgery. The goal might also be to externally empower themselves by meeting the cultural standard of beauty or to deny their own body in order to avoid sexual attention. So I want to talk about some treatment considerations for someone with someone with PTSD and an eating disorders. So first, let's talk about treatments for eating disorders briefly. The best practice for eating disorder treatment is treating at the appropriate level of care based on severity of illness, response to treatment, motivation for change, or motivation for caregivers to implement some of our family-based treatments that I'll talk about. A multidisciplinary team specializing in the treatment of eating disorders that has a mental health provider, a registered dietitian, and a medical provider. In our first stage, we're really focused on restoring our physical health, we call medical stabilization, and contain eating disorder behaviors. So we're doing weight restoration if it's indicated. We're normalizing eating patterns with the help of a meal plan and reducing or eliminating some of the eating disorder behaviors like restricting, binge eating, purging, excessive exercise, or chewing and spitting. In our second stage, we're really focused on relapse prevention and on the comorbidities if they are present. There are many different levels of eating disorder care, ranging from least restrictive and outpatient to our most restrictive and inpatient. In a perfect world, everyone has access to these levels of care and can step down appropriate. For example, inpatient medical stabilization, then they might go to residential. Once they're making progress, they step down to a partial program, and then to an intensive outpatient program, and then an outpatient, they're doing reasonably well and working on some of those comorbidities. I'm not aware of very few patients who've had the privilege of being able to access all of these levels of care in Virginia. As mentioned, I moved here from Portland, Oregon, where it was the norm for individuals to have access to these levels of care, including those with state-funded insurance. So I have hope that we can continue to advocate to get more here. Again, so that's our perfect world of having all those different treatment options. The reality is that our treatment choices are constrained by insurance options. They want to treat at the least restrictive level of care first. And insurance often dictates what provider or facility a person can go to. Available resources. We know that there are limited providers with specialization in eating disorders, especially ones that are in network with insurance panels. And there are a few higher level of care options in the state. And then we have our motivation. If they're an adult, they have to consent to treatment. And if they're an adolescent, parents have to consent to treatment. And nationally, there's a crisis for individuals insured with Medicaid. A recent JAMA article highlighted this issue, that patients with state-funded insurance are under-recognized and under-resourced. My big plug is that step one, if we can continue to recognize eating disorders, then we can continue with advocacy efforts at the state level to push for greater access to eating disorder care. A big role that we can all play to increase access to care is identification. Current guidelines recommend family-based treatment, or FBT, as the first-line treatment for an adolescent eating disorder, where, quote, food is medicine, and the primary focus is using behavioral approaches to increase food intake. Parents or caregivers are empowered to feed their child, and they're encouraged to be present for all meals and snacks. Initially, they take control of all food in efforts to take power away from the eating disorder. Eventually, control over food choices and quantity is given back to the adolescent at their appropriate developmental age, when the adolescent is at a place in their recovery where they can nourish themselves appropriately. Adolescent-focused treatment, or AFT, is the second-line treatment. It's derived from FBT, and it also includes family involvement. However, it utilizes more motivational interviewing to have the adolescent increase their food intake and decrease disordered eating behaviors. Parents and caregivers are used as supports in this as well, but to somewhat of a lesser degree. And because family involvement is not always available, acceptable, or feasible for some families, enhanced cognitive behavioral therapy, that CBTE, which has really good evidence base in adults, is recommended. It does not require parent or caregiver involvement. There is evidence of the use of DBT, dialectical behavioral therapy, as a primary treatment or an adjunct to the above treatments, especially for adolescents with emotion dysregulation and accompanying behaviors such as self-injury, suicide ideation or attempts, and substance use. And there's emerging evidence for what's called radically open DBT or RODBT, which is a relatively new treatment that targets maladaptive over-control and rigidity that we often see in individuals with the restricting type of anorexia, such as suppressed emotional expression, cognitive and behavioral inflexibility, increased threat sensitivity, and reduced reward processing. So I briefly want to review the PTSD criteria, just to kind of talk again how the role of eating disorder plays in this. So we have the exposure to the actual or threatened death, serious injury, or sexual violence, the presence of one or more of the following intrusive symptoms, including recurrent involuntary and intrusive memories of the events, recurring distressing dreams that are related to the trauma, flashbacks, psychological and or physiological reactions to cues that symbolize or resemble an aspect of the trauma. Eating disorders can be conceptualized as a way to avoid or control these intrusion symptoms. One aspect that is part of, I would argue, all eating disorders to some degree is control. And people often explain how they cannot control certain aspects of their lives, but they can control what they eat, how they eat, exercise, etc. We have persistence avoidance of the stimuli associated with the traumatic event. And then we have negative alterations and cognitions and mood associated with the trauma. Things like an inability to remember an important aspect of the trauma, persistent and exaggerated negative beliefs or expectations about oneself, others, or the world. Things like, I am bad, no one can be trusted, the world is completely dangerous. Persistent, distorted cognitions about the cause or consequences of the trauma that lead the individual to blame him or herself or others. Persistent negative emotional state, markedly diminished interest or participation in significant activities, feelings of detachment or estrangement from others, and a persistent inability to experience positive emotions. Again, eating disorders can be thought of as a way to manage some of these difficult thoughts. Also, eating disorders can be a form of self-harm or self-punishment. And victims of sexual violence especially often have faulty beliefs that they are to blame for the trauma, or they may blame their bodies for the trauma. We have marked alterations in arousal and reactivity associated with the trauma, as evidenced by at least two of the following listed here. Things like irritable behavior and angry outburst, reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, and sleep disturbance. Individuals with PTSD can have a really difficult time in eating disorder group treatment settings because of these symptoms. Then we have our duration ones. It has to be more than a month, cause clinically significant distress, and not attributed to the physiological effects of a substance or other medical condition. So I want to talk about some evidence-based treatments for PTSD. I'm going to start with cognitive processing therapy, or CPT. It was developed by Resnick, Chard, and Monson in 2008. CPT utilizes a cognitive behavioral therapy approach to PTSD. In CPT, it focuses on the connections between thoughts, feelings, behavior, and bodily sensations. It teaches one how to evaluate and change the upsetting thoughts related to their trauma. And by changing thoughts, the patient can change how he or she feels. In this treatment, it's not necessary to rehash the trauma over and over again. Rather, you discuss and challenge what they call stuck points, which are faulty beliefs related to the trauma. I do CPT with my patients, and not having to discuss the trauma event over and over again is a relief for many of them, and they're more willing to do trauma work with this. The treatment typically lasts 12 sessions, and it does involve them having to do homework. I want to talk about other evidence-based treatments that have ample research support. It includes prolonged exposure therapy for PTSD, also known as PE. PE is a specific type of CBT that teaches individuals to gradually approach trauma-related memories, feelings, and situations. By facing what has been avoided, a person can decrease symptoms of PTSD by actively learning that their memories and cues are not dangerous and do not need to be avoided. So for this one, again, they're doing just a lot of that exposure and talking about the trauma memories. Eye movement desensitization reprocessing therapy, EMDR. It encourages individuals to briefly focus on the trauma memory while simultaneously experiencing bilateral stimulation, typically eye movements. They do this through tapping, or I've seen people use buzzers as well, which is associated with a reduction in the vividness and emotion associated with these memories. And then there's trauma-focused CBT, TFCBT. It's an approach to help children, adolescents, and their parents or caregivers overcome trauma-related difficulties, including child maltreatment. TFCBT helps children address distorted or upsetting beliefs and attribution and learn skills to help them cope with ordinary life stressors. It also helps parents who are not abusive to cope effectively with their own emotional distress and develop skills that support their children. This is a really great one, especially to use if your patients are younger, because it uses drawings and a book to kind of tell their story. So eating disorders and PTSD, eating disorder patients with a history of trauma are more likely to have a diagnosis of PTSD. Rates range from 1 to 52% depending on the samples. Several risk factors that predispose a person towards PTSD also predisposes them to the development in an eating disorder and may contribute to their co-occurrence. These include things like the female gender, positive personal and family psychiatric history. One pertinent finding is that the majority of individuals with anorexia and or bulimia nervosa have been reported to have a pre-existing or primary childhood onset anxiety or mood disorder. History of childhood maltreatment, including emotional, physical, sexual abuse or neglect, or another previous trauma or adversity. We also have the trauma dose severity. The more likely you experience trauma, the more likely to have PTSD and the eating disorder, as well as a lack of social support. So here are some guidelines for when to start trauma treatment in a patient with an eating disorder. Step one is we need to establish chronology or a sequence of the significant events, trauma, and the symptom onset. You want to educate the patient and family about all disorders that are present. Identify the adaptive functional links between the symptoms and disorders. For example, binge eating, purging, and starvation may serve as possible strategies to facilitate avoidance and numbing, decrease hyperarousal, and regulate trauma-related states. Again, the self-medication hypothesis. It's really important in your work to help individuals kind of understand the role that their different eating disorder behaviors or substance use might be playing to help them avoid the trauma or cope with those trauma symptoms. 4, initially address the greatest danger, risk, and or the brain-body impairment. 5, establish that the patient is nourished or nourishing and able to begin processing information emotionally and cognitively. We know that when a person is significantly malnourished, their brain is usually not the place to do the cognitive work that's part of a lot of these therapies. 6, a patient's eating disorder symptoms are significantly improving / or are relatively under control. 7, a patient demonstrates an adequate level of distress tolerance skills. DBT can be really helpful in having a patient establish some of these. And 8, a patient demonstrates a readiness and willingness to begin trauma work. There are significant treatment gaps for individuals with PTSD and eating disorders. Exposure to traumatic events has been associated with more severe disordered eating and premature termination from eating disorder treatment. PTSD is not adequately addressed in many eating disorder treatments. Again, if you're lucky enough to access eating disorder treatments, many treatment facilities are very direct that they will not treat trauma in the setting, and this is often due to the fact that providers don't feel adequately trained to treat trauma, and they have significant pressures from insurance providers to make the treatment as relatively short as possible. Eating disorders clinicians' familiarity and comfort using trauma-focused therapy is relatively low. And there's also evidence that non-eating disorder clinicians often have negative reactions to patients with eating disorders, including feeling frustrated, hopeless, worry, and a lack of competence in treating this population. Those clinicians receive little training on eating disorders and are not equipped to manage these challenging, often threatening conditions. Also, most programs or providers operate from a sequential standpoint where they've stabilized the eating disorder behaviors and then do the trauma work. And often this is with different providers. And we know that eating disorder treatment alone is not likely to be successful if patients are using their eating disorder behaviors to cope with trauma symptoms. And again, we know that that whack-a-mole phenomenon may occur and other behaviors may emerge. If eating disorder behaviors can be stabilized in our higher level of care, individuals may quickly decompensate as the individual does their trauma work in outpatient. And decompensating and returning to higher level of care can also be a way of avoiding facing the trauma. I've had many patients talk about being too scared to address their trauma, so they return to the eating disorder and decompensate because it's a way to avoid the trauma. And again, treatment also as a way to avoid it, especially if higher level of care is not addressing the trauma. So there's an incredible need for integrated treatment for eating disorders and PTSD. Although difficult to actualize, an ideal integrated model of eating disorder PTSD comorbidity treatment dictates that all conditions are addressed concurrently by the same clinician or program. An integrated model is driven by the hypothesis that eating disorders and related comorbidities are often, at least in part, a result of PTSD symptoms, or that PTSD symptoms are highly relevant perpetuating factors. I'm really proud that the program I was part of in Oregon saw this unmet need for patients. And we were successful in getting a grant for all clinicians who are interested to be trained in CPT, and we are able to offer that to patients in our program. So I wanted to give a case example of somebody that I worked with in Portland. It was a 20-year-old female with a history of significant child sexual abuse who presented to our partial hospitalization program for her eating disorder after being in outpatient therapy for many years. She struggled with restricting, binge eating, and purging behaviors. She also had thoughts of suicide, and she engaged in self-harm behaviors. She recently dropped out of college due to her mental health. Her mother was deceased, and she had no contact with her father, who was the perpetrator of her childhood sexual abuse. And she had some support from her grandparents, who had custody of her after she was removed from her father's home as a child. She was at our program for a number of weeks before stepping up to a residential program to try and contain her eating disorder behaviors, her increasing suicidal ideation and self-harm. Placing her was difficult due to the suicidal thoughts and self-harm behaviors, but a program was eventually found. After about 6 to 8 weeks of residential, she stepped down to PHP again, made some progress, so down to IOP, and then discharged. She returned a few months later to the PHP program after relapsing with her eating disorder, self-harm, and had an increase in suicidal thoughts. After addressing her trauma and outpatient, she discharged from our program after 6 to 8 weeks with some progress. She was readmitted a third time. She had a similar course of treatment. And she was readmitted a fourth time after the therapist on our program had been trained in CBT. She was able to address the trauma and treatment and discharged. And she was stable enough to return to college. And the last I hear, she was doing pretty well. So I want to talk about special considerations for individuals with a history of trauma. It's recommended to have a trauma-informed approach, and this approach incorporates SAMHSA's 6 principles, which are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and also acknowledging and addressing cultural, historical, and gender issues. There are opportunities to incorporate these principles for eating disorder patients. For example, routine weighing of a patient in a professional's office without consideration of the intense anxiety surrounding numbers can erode some of the safety and trust, so being aware of that. Ideally, patients should be offered the choice of whether to be informed of their weights, as well as the option of discussing what it means to them. Eating disorder treatment can feel paternalistic and overly rigid. Describing why treatment is done and the manner that it is very important. I routinely talk about taking control away from the eating disorder so that we can give control back to the person once they're in a place where the eating disorder is not calling the shots. It's also important to give an individual choice and control whenever possible. For example, giving them the option of the flavor for a Boost supplement drink rather than deciding for the person. Again, empowering individuals and giving them choice whenever possible is key. And when you cannot give them choice, describe why, why it's done instead of just saying like, well, these are the rules. There are many, many rules in eating disorder treatment, especially in higher level of care, that cannot be individualized the way that you can when you're an outpatient. And I often explain these rules that we're here to protect all patients against their eating disorders. Not all the rules are going to apply to you or even helpful to you, but we still ask that you follow them to support your peers. So really giving them a rationale. The more clinical considerations, if you're working with someone who has a history of trauma, assess for disordered eating concerns. Honestly, assess for disordered eating concerns with everyone that you work with. Some ways that I do it are just like, tell me about your eating habits. Do you have good days and bad days with food, or are most days about the same? And then what's an example of a good day? What's an example of a bad day? Or if they're about the same, tell me what you ate yesterday. What's your 24-hour recall is what we talk about a lot. Do you ever try and limit the amount that you're eating? What does that look like? Do you ever eat a large amount of food and feel out of control about it? What's that like? Have you ever taken medication or done other things to try to lose weight? Really asking with curiosity and trying to have a non-judgmental stance will go a long way. It's also really important to assess for trauma in individuals with eating disorders. Usually ask, has anything ever really bad happened in your life? I also leave the door open for them to discuss these concerns in the future. I see people hesitate with my question about trauma. I usually stop myself and say something like, you can opt to skip answering this question today and tell me when you feel comfortable, or you're also welcome to change these answers in the future. I know I'm asking you a lot of deeply personal questions today, and you don't know me. It's okay to take some time for you to trust me. With trauma, I'm also really sensitive to the fact that they may be scared of mandated reporting. I always start every intake with discussion about confidentiality and what its limits are. I also let them know that they can ask me questions about who I tell what with whenever they have questions, and if they're ever concerned that it's something I might need to report. Had a lot of hypothetical conversations. I never want an individual to be surprised about a report that I make. And when I do make reports, it's really wonderful when the adolescent is empowered enough to be a part of the reporting process. Not always possible, but when it can happen, it's great. So moving on a little bit from this, we're going to talk about the connection with negative body image and eating disorder and how negative body image develops. So we're going to talk about kind of sociocultural factors outside of trauma. So sociocultural theory of eating disorders argues that individuals experience body dissatisfaction because of the, quote, ideal body internalization, and this may be different for different groups and it changes over time. The tendency to adopt a body as object orientation, the idea that our bodies are objects to judge and potentially change, and the perceived reward to being thin or attractive and the cost to being fat or unattractive. And these three assumptions are primarily reinforced and transmitted by three socialization agents, what we call the tripartite influences: family, peers, and media. We live in a really toxic environment where we are constantly bombarded with messages about food, weight, shape, eating, and exercise. The idea of an ideal body is very harmful, and it leads to body dissatisfaction and disordered eating and exercise behaviors. We also know that body ideals have changed throughout history. The, quote, Thinspiration of the 1990s and 2000s has transitioned a lot to, quote, Fitspiration, which affects both men and women. Here are a few advertisements highlighting the thin ideal and the fit ideal. And again, they have messages that if you engage in these exercise behaviors, you too can have this body. The hourglass ideal is inspired by the Kardashians. I've heard about this YouTuber, Chloe Ting, from so many of my patients. She has these workout challenges and food challenges that tell you, the hourglass booty workout, how you can, again, change your body to have this if you just do these exercises. Here are some more examples of ideal bodies represented in TV. We have America's Top Model, Too Hot to Handle. Not pictured are all of the shows that have been around about changing people's bodies, like The Swan, Biggest Loser. A new one is called Glow Up. And here are some advertisements of how to change your body. I threw in a historical one to highlight that, again, the quote, ideal body is ever changing. And as long as we say that some bodies are, quote, good and some bodies are, quote, bad, then there is a problem. Seeing ideal bodies everywhere leads to this an ideal body internalization, where an individual cognitively buys into this socially defined beauty ideal. Because the ideal is unrealistic for most individuals, this ideal internalization is thought to directly lead to body dissatisfactions. There are many studies that highlight this phenomenon. One of my favorites is where researchers recruited individuals who did not have eating disorders, and they had them complete a body image questionnaire to start with. And then for the intervention, one group saw pictures of ideal bodies, and the other group saw pictures of neutral things like flowers, houses, and landscapes. And after the intervention, the participants who took the body image questionnaire again. And so the group that saw like the houses and the flowers, their body image was the same, not bothered. But the group who saw the ideal body images had significantly lower body satisfaction. And I often talk about this study with patients to, again, talk about we are all affected by these images and by our media and by the way we talk about these things. So talking about social media, there is clear evidence that social media use is linked to eating disorders. Social media is a major vessel in which diet culture and body ideals is transmitted. Social media contributes to body image concerns and psychological distress. And we have good research that shows that excessive use can lead to toxic social comparisons and negative body image. I recently learned that more than 70 lawsuits have been filed this year against social media platforms, including Meta, Snapchat, TikTok, and Google, centering on claims from adolescents and young adults who say they've suffered anxiety, depression, eating disorders, and sleeplessness as a result of their addiction to social media. And in at least 7 cases, the plaintiffs are the parents of children who have died by suicide. The suits make claims of product liability that are new to social media, but have echoes of past campaigns against tobacco companies and automobile manufacturers. So the ideas are really trying to target and get social media to have some regulations and to change through lawsuits because our research is so far behind what's happening. The Social Media Victims Law Center, the SMVLC, was founded in 2021 to hold social media companies legally accountable for the harm they inflict on vulnerable users. The SMVLC seeks to apply principles of product liability to force social media companies to elevate consumer safety to the forefront of its economic analysis and design safer platforms to protect users from foreseeable harm. You're welcome to share this resource with your clients. I have a parent that I work with who's actually looking into joining one of the class action lawsuits against Instagram for contributing to her daughter's eating disorder. With social media filters, there's clear evidence that filters can lead to negative body image. Both Instagram and Snapchat platforms have beauty and augmented reality facial fillers. Settings like the, quote, enhance feature on TikTok or the, quote, touch up my appearance on Zoom deliver flawless skin for videos. Editing apps such as Facetune, which saw usage increase by 20% at the beginning of the pandemic, has over 1 million edited images exported daily. It allows users to smooth, shrink, and sharpen their way to perfection. It's never been easier to picture your ideal face and see your, quote, flaws in your actual face. I really like this quote that said, before social media, the source of our insecurity was failing to meet the beauty ideals modeled on magazine covers. Now we compare ourselves not only to the airbrushed elite, but to our airbrushed peers and our airbrushed selves. The rise of face fillers and editing apps have been correlated with a surge in cosmetic surgeries. One study showed that the use of filters on social media has a significant association with subsequent desire to undergo facial cosmetic procedures. Interestingly, the study also showed that a history of prior psychiatric diagnosis was also independently associated with a desire to undergo facial plastic procedures. In 2018, 55% of plastic surgeons reported that their patient surgeries were motivated by a desire to look better in selfies. And many young individuals actually bring in filtered pictures of themselves to show or describe to the plastic surgery what they want done. Another good quote, these face filters are using algorithms to reinforce a certain standard of beauty that is very narrow. That standard, Instagram face, characterized by high cheekbones, poreless skin, pat-like eyes, and plump lips. Even worse, people assume that this unique combinations of features is attainable. Even online health and wellness content may have negative consequences for users. Messages about weight management through diet and exercise are shared widely and receive high levels of engagement. Things like, quote, what I eat in a day became really popular. And also the idea of becoming what they call, quote, that girl or that guy. And it's defined as the person who eats healthy, exercises daily, and typically has a, quote, ideal body. A, quote, glow up shows a before and after picture of a person, usually with dramatic weight loss. And here's a book actually found while researching this talk called A Glow Up Gone Wrong. And its book is written about a parent or by a parent, and it chronicles the author's 16-year-old daughter's almost deadly fight against anorexia. So individuals see these things trending, such as glow up or what I eat in a day, and they try to recreate it in their own life. Eating disorders often start off as an innocent attempt to be, quote, healthier. Many of my patients I work with have talked about these health challenges that were going on during the pandemic on various social media sites, and that they engaged in that directly led to their eating disorders. Individuals are often praised, both online and in person, at first for making healthier choices, quote unquote, which may quickly become problematic and disordered, such as rigid exercise routines, the timing of their meals and snacks, eating, quote, clean, or completely cutting out whole food groups. Individuals living in larger bodies are routinely celebrated and praised for their weight loss, despite them engaging in very disordered behaviors to lose weight. These individuals are often diagnosed with atypical anorexia, and in this diagnosis, it encompasses all of the diagnostic criteria of anorexia, except that although the person has lost significant weight, their weight remains at or above what is considered, quote, normal or acceptable for their height. So I want to just give some little facts about atypical anorexia. It often takes longer to be diagnosed. Atypical anorexia is just as dangerous as anorexia. There is no difference in occurrences of bradycardia, the slowed heart rate that is usually probably our number one indicator of why we hospitalize adolescents. Those with atypical anorexia typically have greater overall weight loss than those with anorexia. One study showed kind of an average of 39 pounds lost versus 24. And psychiatric comorbidities and suicidal ideation are not statistically different from those with anorexia and those with atypical anorexia. So I do want to talk a little bit about individuals get to this content that I'm talking about. Of course, you can choose to watch certain TV shows, Google certain topics, etc. but just being on social media can take people to dangerous content because of the algorithms. TikTok has really strong algorithms. It rapidly identifies a person's interests, and it sends adolescents and others into harmful streams of content that can trigger an eating disorder or a relapse. Facebook and Instagram are actually learning these algorithms, and their new reels are essentially TikTok videos. These algorithms are good. I don't spend that much time on TikTok, but it has me pinned down to my age range, being a mom of young children, a therapist, and other interests. And it's fun being delivered content that's so in line with my interests, but sometimes our interests are not self-protective. Because these algorithms are dangerous because individuals aren't necessarily seeking out this content. Pro-eating disorder content, it's also been known as pro-Anna or pro-Mia. It's not new. It's been around since the dawn of the internet, but individuals used to have to seek it out on the web. Now individuals may start watching videos about a sport that they like, which leads them to a "what would I eat in a day" video for people trying to maximize their training in their sport. And then that sends them to someone who posts a video about their eating disorder, and the user watches that. And the more you watch content, the algorithm will identify an interest and send them more and more content related to, say, eating disorders, and maybe into the harmful pro-eating disorder content. And the same phenomenon is happening with intentional self-injury, suicide attempts, depression, and other mental health concerns. And consuming this content normalizes really dangerous behavior, and it often glamorizes the illness. For eating disorders, that could look like bragging about hospitalization, residential treatment, feeding tubes, these, quote, badges of honor in the eating disorder community to show how sick one is. And the sicker the individual tends to get more attention on online platforms. And also hashtag recovery or hashtag eating disorder awareness may not be very recovery oriented and may highlight extreme low weight, which can be really triggering for individuals and perpetuate this idea that individuals with an eating disorder are only low weight, which is incorrect and problematic. So I talked about how social media a lot because it's a newer vessel for body image concerns. But we know that comments and behaviors from friends and family are also very powerful. We talk about appearance literally in utero. Look at how cute he or she has a button nose. Early growth for babies is tracked in pediatrician's office. I had premature twins who were in the NICU, and there was so much focus on their weight gain, making sure that it was enough. And then I remember when they were about 6 months old, there was some concern that one of my twins' BMI was getting too high. And it felt just so frustrating how much focus was on their weight and how narrow apparently that weight criteria was. Friends and family and strangers make many comments about size and shape and appearance, starting again when babies are born. What a cute baby. She's got chunky legs. Look at that big belly. I hope she grows out of it. You know, it's those, again, messages just come from the very beginning. Research from the Professional Association for Children in Early Years, called PACE, reveals that anxieties about body image concerns are starting in some children as young as age 3. 37% of childcare workers have heard statements about how she or he is fat in their setting, and while 31% have heard a child call themselves fat. 1 in 10 workers have heard a child say that they feel ugly, while 16% of early years workers have witnessed children saying that they wish that they were pretty or good looking as someone else. This figure almost doubles as children get older. Nearly half, or 47%, of child carers have witnessed body image anxieties in 6 to 10-year-olds, and around 1 in 5 children have been seen rejecting food because, quote, it will make them fat. Carers believe that these body anxieties are coming from peer groups, parents, and media. More research is needed in this area. The contributing factors are likely to include images on TV, images in storybooks and animations, and the general chat by adults about their bodies, dieting, cosmetic surgery, etc. There's little doubt that low levels of self-esteem appear to contribute significantly to negative perceptions of body image. And I thought this was just a interesting picture. It is some of the messages that young girls learn from Disney princesses. From Snow White, they learned that pretty girls don't even need to be alive to get some hot princely action. For Snow White, at first it may seem terrible, being so beautiful that other women get jealous enough to try and kill you. But don't worry, once your beauty attracts a man, he'll protect you from Snow White. Ariel, it's okay to abandon your family, drastically change your body, and give up your strongest talent in order to get your man. Once he sees your pretty face, only a witch's spell could draw his eyes away from you. Cinderella, if you're beautiful enough, you may be able to escape your terrible living conditions by getting a wealthy man to fall for you. Belle, appearances don't matter. What counts is what's in your heart, unless you're the girl. And Jasmine, as a woman, your political worth is reduced to your marriageability. I could do an entire hour and a half talk about images that our young girls and boys see that influence body concerns, but we don't have time for that. Okay, so we have negative body image from comparing ourselves from our culture, right? And then we have a diet culture, because where there's dissatisfaction, we have what we promise will make us happier, a diet to change ourselves. The term diet culture has been coined to discuss our society's toxic environment. We are constantly bombarded with messages about food, weight, shape, eating, and exercise. Simply put, diet culture is a society that focuses on and values weight, shape, and size over wealth and well-being. So here are some good examples. One, feeling like you can't escape conversations about weight, diets, good and bad foods, cutting carbs, detoxing, cleansing, calories, macros, etc. Two, exercise is advertised as a mode for weight loss, a means to become more attractive, or punishment for eating. Three, weight loss challenges in workplaces amongst family members or friends. Four, a healthcare provider that focuses on BMI and overlooks assessing other health markers, fitness level, mobility, and psychological well-being. Five, before and after photos, thin ideals, fit ideals, anything that generates a fear of fat or positions large as less valuable. And six, praising people for vigilant eating and or weight loss. So now let's just talk about some interventions for when negative body image is there, and also some prevention efforts. For interventions, our biggest thing is just first do no harm. Like as I outlined with some of diet culture, there's so many things that's part of our society that is problematic. We need to end things like BMI report cards in schools, although thousands of schools currently send BMI reports to parents. Research shows that the practice alone has no impact on pediatric obesity and may decrease student weight satisfaction, i.e. create body image concerns. We need to stop using weight as a sole indicator of health in schools and physicians' offices and your social circles. Don't comment about appearance, kind of positive or negative. It continues to put that emphasis on that being very, very important. Instead, give more personality-based compliments. Stop teaching about, quote, good foods and, quote, bad foods. We need to look at that picture to the right? We have good foods are just foods, and bad foods are things like rotten or spoiled food, foods that you're allergic or intolerant to. Again, these are bad for you, but not for everyone. And then some jokey responses that food that's trying to rob a bank, or food that calls you names at recess. We need to work on neutralizing our language in regards to food. You can talk about what foods do for our body in healthful ways. In our work, we often talk about adding in food versus limiting when we're working on trying to change people's kind of food intake. We focus a lot on getting all of the different food groups in at meals. Again, focusing on getting enough to eat without demonizing any food, because all foods fit in a healthful diet. Our goal, again, is to de-emphasize the focus on weight and appearance and food. Some more interventions. The Body Positive. It's a nonprofit organization that teaches people to listen to their bodies, learn, and thrive. They provide trainings to educators and student leaders to create body positive programs in schools and communities. For negative body image, when I'm working with people, I often talk about moving kind of to a neutral space and to acceptance and then positivity. It can be really, really difficult for people to go to a place of I hate every inch of myself to I love myself. So we start with acceptance, a place like this is fine, my body is fine. I accept it for what it is and that it's the vessel that allows me to move through this one precious life that I have. Moving to a place of gratitude for your body. My legs allow me to walk and run. My arms allow me to hug my loved ones. It can also be helpful to be curious about your ancestors and traits that you shared with your loved ones. Things like I see my grandmother in the shape of my hips. I have my father's nose. I carry the threads of so many before me, and I'm grateful for how they show up in my body and connect me to them. We also work to help individuals reduce their own negative focus on weight, shape, and body. We help with, our big goal is to stop body checking behaviors. So we can do things like remove mirrors, cover them if you can't remove them, or decorate them with affirmations, things like I'm smart, I am kind, I am enough, my body is awesome just as it is. Stop talking about your body and other people's bodies, including strangers and individuals in the media. We often encourage people to get rid of what we call, quote, sick clothes or, quote, goal clothes, clothes that don't fit and just make people feel bad about themselves. We also encourage people to cut out sizes in clothes if people are hyper-focused on those. We also do education about size variation and remind individuals that when you shop, you look for clothes that fit you and don't make your body fit into clothes. I do talk about how it's appropriate to give some care and concern to our bodies and our appearance. We give some thought into how we present ourselves to others and the world, but it should not be the most important thing or take up the majority of our internal thoughts. Interventions for body image after trauma are a little different. Treatment for body image after trauma needs to address that it's not the body's fault for being victimized. We often combat rape culture ideas. And again, rape culture is the setting in which rape is pervasive and normalized due to societal attitudes about gender and sexuality. It includes things like victim blaming, slut shaming, and sexual objectification. So I remind people that it doesn't matter what you were wearing when you were victimized. To the left is actually exhibits that have been gone on at a lot of colleges, kind of showing what people were wearing when they were sexually assaulted or raped. I also remind people that it doesn't matter if you were drinking or used substances, it wasn't your fault. We also really normalize body reactions to abuse. Things like it doesn't matter how your body may have responded to sexual acts that were against your consent. Those are automatic processes that can be really confusing. I really work on assisting the person and placing blame to who it belongs with. And that person is the person who is culpable, the person who engaged in a sexual act when you didn't give consent, including if you were unable to give consent. So prevention efforts. Starting when our kids are really little, be aware of what your children is watching on media and in the world. Be aware that your child is listening to you and watching your behaviors around food. Kids learn from us. I have 3-year-old twins who ask me 1,000,001 questions a day. And some of those are, why are you eating that, mommy? And saying like, because I'm hungry, instead of, because I can't control myself. It can also be difficult when comments are about our bodies. The question like, mommy, why does your stomach look like that? And answering like, because that's how my stomach was made. Isn't it neat that all of our bodies are different? We want to build their self-confidence and self-image by focusing on who they are as a person, not just what they look like. You were so kind to your friend today. I'm so proud at how hard you're working on that. And representation matters. Body diversity in marketing. I try and support businesses that have diverse body sizes in their marketing and also carry a large range of sizes of clothing. And body diversity in TV shows and movies, especially in lead characters. It is so important for people, especially those who are marginalized, to see people who look like them represented in media. and learning about HAES and the importance of size diversity in health. And a little bit of prevention efforts in regards to social media. It's really important to empower youth to be critical about what they see in media and hear in their lives. Talk to them about diet culture and body ideals. I love educating teens on this topic. Many of them already know so much about it and they've had exposure to these terms. Validate their feelings and empower them to get angry about our society and discuss ways that they can change it. Discuss their social media use. Remember that social media is not inherently good or bad. Social media likely isn't going anywhere. So a lot of our role is helping teens to reflect on their own social media usage and develop the skills to be self-protective with their use. And let's be honest, adults are not immune to this either. And we're also learning how to have this balance and engage in social media in a self-protective way. So I often ask questions of, how do you feel after spending time on social media? What are some good things about social media? What are some things that aren't so good? Are you engaging in material that makes you feel good or bad? If they're recovering, how can you limit the content that's triggering or hinders your recovery? Can we look at your social media accounts together and talk about them? So last on the agenda is talking about size diversity and health at every size. Health at Every Size is a movement that was built on the foundation of challenging weight biases. HAES is an evolving alternative to the weight-centric approach that promotes and embraces size acceptance, body diversity, strives to end weight discrimination, and lessen our cultural obsession with weight loss and thinness. It promotes balanced eating, life-enhancing physical activity, and respect for diversity of shapes and sizes in our worlds. HAES is really de-emphasizing the importance of weight. We know that there are people who are, quote, average weight that may have health concerns, and we know that people who live in larger bodies may not have health concerns. Weight alone is not a good indicator of health. Part of an effective treatment and prevention for eating disorders is combating harmful diet culture, accepting and celebrating diverse body sizes and shapes, and accepting and celebrating diversity in all of its forms, race, gender, sexuality, etc. So, a lot of us have our own work to do in terms of ending the cycle of diet culture in our own life. The first step is to identify and challenge the ways that you may think about weight and size that may be rooted in diet culture. Changing the way you think about these topics is the first step and to help us dismantle diet culture, and then engaging in some specific behaviors. Just a good little RESPECT acronym. So R, rest when your body needs to it. E, eat a variety of foods to fuel yourself, but also for fun. Food's a huge part of our culture and a way of connecting with other people. It's also enjoyable. Speak up against body and weight stigma. Engage in media and size diversity. Protect your mind and your mental health. Again, be mindful of what you engage in with online and in person. If you're in a group of friends and family that tend to engage in a lot of diet talk, change the subject. There are so many more interesting things to talk about. E, exercise moderately with joyful movement. Remember being a kid and playing with friends outside, not to lose weight, but because playing hide and seek was fun. Find activities that are fun. If you hate running, for example, don't run. Join a kickball league, try an adult dance class, karate, etc. Try and stay away from fitness regimes that are focusing on changing your body size and shape or punishment for eating. C, change the culture by supporting overall well-being. Recognize that physical health is one aspect of overall health, not all of it. And treat every unique body with respect, including your own. Okay, I'm going to leave you with a few resources. The National Eating Disorder Association, NEDA, it has a ton of information about eating disorders, and it also has different sublinks for a lot of marginalized communities. Association for Size Diversity and Health. And then here are a couple professional organizations that have further education and training: Academy of Eating Disorders and the International Associations of Eating Disorder Professionals. I listed 3 podcasts that I know of that I think has pretty good material. I haven't listened to every episode. The Eating Disorder Trap, ED Matters and the Eating Disorder Recovery podcast. Also below are my 3 favorite current books right now. One is about the plate by plate approach, talks a lot about healthy relationship with food and eating. Skills-based caring for a loved one with an eating disorder. It gives a lot of really practical advice about how to talk about eating disorders and how to engage with an individual. And then Sick Enough, it's a guide to medical complications of eating disorders that's really, really in depth. Kind of covers everything. And then last, I'll leave you with some resources for all of those trauma treatments that I talked about. So we have CPT for PTSD, the trauma-focused CBT, prolonged exposure, and EMDR. And with that, I will open up the floor for questions or comments.
Okay, Sarah, so we have had a few questions come in.
Okay.
And if I mispronounce, I'm going to start off with this first question, and I'm going to say this as an acronym, but is ARFID, ARFID, associated with body image, or is it linked to sensory processing disorders?
That's a great question. If you'll notice, I didn't talk about ARFID at all today because it's not related to body image. It's related to, there's a couple of key criteria for when people experience ARFID. Basically, they're not eating enough food for a variety of reasons. One may be that they're very selective eaters, they're very picky, and that may very much have things to do with that sensory processing. They're kind of sensory avoidant, and they don't like the way that certain foods taste or feel. It can be just having apathy around food, low appetite. And then one is having a traumatic event with food, like a choking episode. So they're fearful of any eating, and that limits their eating. And the key criteria is that it's not related to body image, size, or shape. And, you know, if I have somebody who I'm working with who denies body image concerns, so it seems like they have ARFID, and then as we're doing the treatment and they're gaining weight and those body image concerns come up, then we switch that over, and that's a different eating disorder, one of the ones that have the body image concerns.
All right, let's move on to, is it appropriate to serve these clients in a CSB setting, a community service board setting? Are their needs able to be met by generalists?
That's a really good question. I think that these patients are being served in CSBs, right? Because you guys have access to them and they need a lot of mental health support. And so I think many of them do have eating disorders. And whether, you know, I think getting some good training on treating the eating disorder piece can be important, but I will say that you can be a wonderful support and kind of co-counselor. I actually share a number of patients with different CSB counselors, and it would be great, you know, if you're working with me or another eating disorder clinician, for you to know what they're working on so that you can just kind of support that work. I think utilizing tools such as distress tolerance, skill building, going to school, some of these really practical goals we have can be very important. And I think also broader, you know, so much of our work initially is focused with getting that meal plan in and just being another voice who's kind of checking in about that and helping build some of the behavioral supports to do that. You know, I've had some conversations about, like, it would be wonderful if we could get some in-home counselors to have some training on just meal support, because that would be such a wonderful practical way of supporting some of our outpatient kiddos when they're at home, you know, just sitting with them and having a meal and giving them support in that way. So maybe not quite yet, but I think like opportunities exist, and it's happening.
All right, thank you. Is there a resource list somewhere we can access for those higher levels of care options for eating disorders in Virginia?
The short answer is no, because I'm like, all of these patients have Medicaid, and I will say that we are having tremendous issues finding higher level of care for our patients with Medicaid. We're at Teen Health have contact with some attorneys that we're trying to advocate to get them to higher level of care. The only two that we know of that we've had some success with are Cumberland and Dominion Hospital that are located in Virginia. The pandemic has been really challenging because it used to be that some of the private hospitals were more willing to give single case agreements. Like those are kind of the ways to a lot of the higher level of care. But as their numbers have been so high and have a wait list, we've had a lot less success in doing that. So there is a huge gap in care for our patients with Medicaid.
All right, so back when you were talking about body images, this question came in was, how does this apply to Black and brown girls? Their bodies are not generally celebrated as ideal.
Yeah, I think that that's, again, a problem, right? That their bodies are not celebrated as ideal. So that's lack of representation. That's lack of having it up there at all. And that definitely affects body image, not being represented at all.
All right. How do you have the conversation with individuals who have a diet-related health condition, such as diabetes, who might also have a co-occurring eating disorder?
Yeah. So we actually know that people who have, well, I guess my first question is type 1 or type 2. We know that individuals with type 1 disorder are actually at heightened risk for an eating disorder, and they also can use their insulin in maladaptive ways to basically purge. It's a little bit trickier because they have to be aware of like their carb content. So in a lot of our traditional treatment with eating disorders, we're removing numbers and trying to de-emphasize that focus. But with somebody with type 1 diabetes, we're definitely having to pay attention to that so they can dose their insulin correctly. So it's mostly just continuing to have those conversations, and we're not labeling foods as good or bad. We're focusing on what carbs you're eating and then how we dose insulin appropriate for that. If it's type 2 diabetes, so see, we have somebody who's living in a larger body who is experiencing some health consequences because of that, like type 2 diabetes. We talk a lot about kind of that piece I touched on about adding in. Our dietitian, who phenomenal, she talks, at breakfast, let's make sure we have all the different food groups, because part of that, right, if we're having all the different food groups, then we're going to have our different groups that keep our blood sugar pretty regulated until the next meal or snack, because when we're over hungry, we tend to go and grab quick, high energy things that give us that quick energy and may not keep us satiated. So we don't focus on limiting, we focus about adding in and creating kind of that balance. And, if they have diabetes as well, we'll be talking about medication management and things to support that.
That question came from Catherine Hetrick. Catherine, did that answer your question?
Yes, it did. Thank you.
Okay. All right. Let's move on to, what are some of the benchmarks for different levels of care? Are there any special considerations for children 12 and younger?
For all kids under 18, we want family support. And if it's under 12, I argue like absolutely family support. For most kiddos, we try to start an outpatient and do our family-based treatment. And I also just think if the younger that they are, this might be a longer road. So having parents be very trained in the treatment of FBT, again, where they are providing the food and support at home, is going to be really, really important. If they're unable to make progress at home and FBT is just not working, there are a couple of residential facilities who take kids like really young. I think we've had like 9-year-olds go to like Veritas in North Carolina. So I think that's the question. Let me know if I didn't answer that.
Casey, did that answer your question?
Yes, thank you.
Okay. I just want to make sure the questions get answered.
Yeah. And anyone, if I'm not answering them, please type in and be like, that's not what I meant. This is what I meant.
All right. Next up, we have a question from Tina. What's a good way to talk to a client about an eating disorder who has gone to great lengths to hide it and doesn't want to acknowledge that this is the issue? Family is also in denial. They focus more on physical symptoms like stomach pain as the reason they don't eat.
Yeah. needs are challenging. I think it's continuing to highlight discrepancies that you notice. Like, I'm seeing these behaviors and I'm really worried about it. I think also if they're unwilling to acknowledge an eating disorder because of, body image concerns, I just bring it back to this place of, regardless of why we're not eating enough, you're not eating enough, and that's a big problem. So if you're having the stomach pain, we've got to figure out a way to get you properly nourished. How do we manage this pain? I'm curious if they're hooked up with like GI at that point, or if they have kind of a functional abdominal pain diagnosis. Again, regardless, our message is you're not eating enough and we got to figure out how to eat more. And if they haven't seen a doctor, to try to see a doctor. Sometimes getting some medication for that, even things that are kind of like antacids, can do a pretty big placebo role. Or you can say, like, we have the medication for this now and you're still not eating enough. So we got to focus on that. And I think another big piece is highlighting, we didn't talk about it much in this talk, but how much under eating really affects our mental health, our kind of more likelihood to experience depression and anxiety, or may worsen pre-existing conditions with that. We also know that if they're on any antidepressants, that those medications aren't going to work properly if we're not properly nourished. And again, just kind of giving that education about how under eating is affecting their both physical and psychological health.
Thank you.
All right. We work at a CSB and do not have a lot of specialized resources in the area. Do you recommend in-person sessions versus telehealth when treating eating disorders?
I think it depends. So with the pandemic, I used to be 100% in person, and now I do have more telehealth now than in person, just because we have people who drive from hours and hours away. I think that in person is great whenever it's feasible. I do think that telehealth has opened the doors for a lot of people who wouldn't be able to get this treatment to get it. And I think that that's worth it. I see, like I said, a lot of kiddos in telehealth. It also helps with the frequency of visits. With telehealth, I can see people once a week instead of like once a month when their parents can drive them to clinic. Can also take out a little less time of their day. Like they can often like log on from school sometimes to do a session. So I think my answer is like, I think in person is always better because it's nice to connect in that way. But when that's not, again, feasible or easily done, then telehealth is really good too.
All right. Is there a negative connection? Nope, sorry. Erase. Is there a connection between negative food talk and eliminating whole food groups for children since birth and development? And wow, I just got to tell you, I think I'm butchering this. Sarah Hickey, this is your question. Would you mind unmuting for this, because I'm going to do it not proper justice. Sarah, are you here? All right, well, let me try. Okay, is there a connection between negative food talk and eliminating whole food groups for children since birth and development of an eating disorder? So is there a connection between negative food talk and then eliminating whole food groups for children since they were born? Does that cause?
Yeah. I mean, nothing necessarily causes anything, right? Like, I mean, I think like negative, we all are exposed to this culture and not all of us develop eating disorders, but is it contributing to it? Probably. And yeah, right? Like, so we're demonizing some foods, or we're saying it's off limits, and all of that increases our focus on it, or may make the person feel bad for not doing it, so on and so forth. So I think, unless there's a medical reason why we're eliminating the food group, the recommendations really are to have kids be exposed to a wide variety of foods, and that no foods are talked about as good foods or bad foods. That's kind of the recommendations, just to support people with having a healthy relationship with food in the future.
Okay, so then Sarah follows up with, how do you support parents that contribute to this talk and refuse to incorporate a variety of foods?
Oh, not easily. I mean, I think keep having these conversations. So much of it is getting enough buy-in from people. I think it really depends on what's going on and where their child's engaging with this. But we certainly struggle with that when we meet with parents who don't want to stop their own kind of diet behaviors or bring in foods to the house that they perceive that are bad. And so we really just continue to talk about our recommendations and why it's important. But ultimately, we can't make people do things that they're not willing to do.
Well, apparently that's a theme, because the next question says, how do you work to get parental buy-in for CTS when parents believe body shape size is cultural?
Buy-in for CTS what's?
Yes, buy-in for CT, is CTS a thing?
Not that does it mean like FBT or?
Let's see, who is this? Tawana, can you unmute yourself? Actually, I can unmute you to ask this question because you wrote CTS.
Yes, I'm sorry. That was an abbreviation for clients.
Oh, okay.
Occupational hazard. Sorry.
No, that's fine. I was like, I don't know CTS. Sorry, can you repeat the question?
So how do you work to get parental buy-in for clients when parents believe body shape or size is cultural?
Yeah, I think a lot of it is working with the clients directly and then talking about how their parents' beliefs affect them or don't affect them, and I think the one thing that's neat about working with adolescents is starting to plant those seeds that they can have their own thoughts and that they can, learn about these things and independent to it. But yeah, it's hard. I think it's, again, kind of education and just doing a lot of Socratic dialogue and asking them how they feel about different things and how maybe the messages that their parents are giving, like, how does that make you feel? Like, what do you think about that?
All right. Are individuals also educated about how eating disorders can affect their dental health?
I usually touch on it a little bit. There's kind of two ways it does. One's just general malnutrition. We know that our teeth are bones, and so malnutrition affects all our bones in our body, also our teeth. And then when people are engaging in purging behaviors, I definitely talk about that, how the frequent kind of bringing up acid from the stomach can quickly erode the teeth and can cause a host of dental complications for the future. We usually kind of, when there's purging behaviors involved, I talk a little bit about the physical and psychological repercussions to it.
Okay. Are the reasons the same for men developing eating disorders as women?
Maybe, kind of that first slide, that there's a wide variety of factors that can lead to an eating disorder. So I don't think being a male or a female is necessarily going to be different in that kind of different combination of things that can happen. Like so much of the body image ideals too, it's like depending on what group you're part of and what ideal, we know that, men's body pressures may be slightly different than women's body pressures, or they may not, right? We know there's some research about specifically kind of in gay male groups that there's more of a focus on being very, very thin compared to a heterosexual male group, where maybe it's focused on being very big and muscular. So not any more than I think it's different for everybody, kind of that perfect storm that happens.
All right. That's all of the questions that I pulled from the chat. Is there anyone here who has a different question, a new question, a follow-up for Dr. Stevens? Sandy O'Bannon wants to know, have there been any studies of generational differences in frequency?
And frequency of eating disorders?
I'm going to guess that's it. Sandy, is that what we were saying? Yes.
Yeah, I mean, the research, there's statistics that show that eating disorders are becoming more prevalent and more common. It's hard to know if I think it's probably a combination of, yes, I think eating disorders are probably becoming more prevalent. And two, I think our identification is getting better and better because historically, again, kind of when eating disorders were first identified, it was incredibly problematic of just focusing on females, mostly thinking very privileged groups and white. And so there's been a lot of work to expanding that of every different race and culture, all of the genders, all the different body sizes and shapes. And so I think it's, again, a mix of, yes, they're getting more prevalent and our identification's getting better. We still have a long way to go with that.
All right. How do you suggest working with youth who participate in sports that often focus on size, such as ballet or ice skating, wrestling, and have led to some symptoms of eating disorders, like breaking the connection of weight and image and success in sports?
Yeah. I think it's talking with them a lot about it. When people are in active treatment, if we typically kind of take away sports for a minute, if they're not in a medical place to do it. And then when we return back to those sports, we have a lot of conversations about, is this a helpful sport? Can you stay safe from your eating disorder while you're engaging in the sport? So I think it's, teaching them how to be thoughtful about it. And if their parents are involved and it's not a helpful place, so, having those conversations with parents about maybe the sport's not the best sport for them to do right now, or maybe moving to a sport or a gym or a team that's not so weight focused, right? Like I think, with dance, there's a wide variety of dance studios out there. So there are dance studios where somebody may be incredibly diet centered and say incredibly problematic messages about body size and shape. And there may be I've heard some really great dance teachers who celebrate body diversity, encourage their kids to eat, and it's actually a really positive environment. So I think a lot of that can come down to kind of the specific environment and coaching, and again, maybe seeking those out if they're in a team or a coach that's not supportive or helpful.
All right. Are there any opportunities to connect people who are struggling with eating disorders with individuals who have recovered?
Yes, off the top of my head, I'm not sure exactly what those are. There's kind of a new thing out that I think is pretty much all private pay at this point, called like eating disorder coaching, where people who have recovered from an eating disorder go through some training to basically be coaches for others. I don't know a lot about it other than just kind of knowing that it exists. I think mostly for the adult world, and again, that it's mostly private pay. I will say that in general, there's kind of, in connecting people with eating disorders or even those who are recovered, it's making sure that people are in a place of good recovery. And when they're not going to engage in conversations that are going to be really triggering for the person still active. So we really recommend that people not talk about specific weights, specific behaviors that they were engaging in, just because eating disorders can be so competitive. And so that can be kind of a tricky thing. And again, the only kind of formal thing I know about is the eating disorder coaching, which is generally usually part of kind of a broader treatment setting as well.
Lauren Kiefert has shared in the chat that there's an organization called Project Heal, which connects people to those struggling with recovered individuals. So that's Project Heal.
Yeah, Project Heal is a really great resource too. And every now and like they have some grants available for treatment sometimes.
All right. Well, that is the last question that I can see in the chat. So I think that we're finished with you. Sorry. No, just kidding. I am going to, if you would stop sharing, thank you. And we're going to add our glorious Mia McCoy here to the screen so she can address everyone.
Thank you so much. Aside from my interests, my research, and my work in substance use, eating disorders is my first love. And that opened the door to the work for substance use. And I will say I learned a lot today. So thank you for your insight and for your obvious passion and just for being with us this morning. So we're going to take a break for lunch. And during our break, we're asking that you stay logged in. Just turn your cameras off and come back at 1 for our next panelist. Thank you.
Thank you so much, everyone. I'm going to be logging off.
Welcome back. I'm Mia McCoy with the Office of Child and Family Services. And now I will introduce our next panelist, Ms. Ashley Williams. Ashley Williams is a yoga therapist and mindfulness educator with 12 years of experience in the fields of education, behavioral and mental health, and community programming in Richmond, Virginia. As a builder and weaver, she bridges mindfulness, diversity, wellness, and inclusion on micro and macro levels to achieve equitable, socially stable, and conscious spaces for individuals and collective care. She's the founder of both Bare Soul Yoga and Wellness, a community-based organization founded in 2015, initially created to offer accessible yoga offerings and mindful on life and mindfulness and movement, both curriculum-based programs dedicated to transforming community through the practice of mindfulness education. Currently, she is the mindfulness director at Martin Luther King Jr. Middle School. Ashley serves on the board of directors for the Robinson Theater and Accessible Yoga. She is full of inspiration, life, and experience to guide efforts in creating spaces for people of all ages and backgrounds to be educated and empowered through the practice of awareness. Thank you, Ashley, for being here. We are all appreciative and excited to hear you present. So thank you.
Welcome. Good afternoon, everyone. It's been a pleasure to be with you this morning. And today we're going to be navigating, historically marginalized communities and eating disorders. And so as we go into this conversation, I invite you all to do what I do in most of the places that I begin, and is really just to take a moment. We've had a break. We've had a break from beginning the morning with really incredible information, and I'm so grateful that I sat in on it, just to kind of really hear the impact of trauma. And we'll kind of dive a bit more into the marginalized community space today. And so as we go into that space, I want to start us with just a moment. I know we might be doing various things and taking in this information. And so just taking a moment to check in. Today's opportunity is really all about awareness. And so I know we're all in different places and we're coming from a break and from lunch. And so as we do this today, I'm going to invite us into a moment. And so as you get settled, take a look around the space that you're landing in. Maybe you shifted locations from the day where the day began. But taking a moment to take a break, taking a moment to take a pause, take a mindset shift, take a breath. And so I'm just going to take a few moments to guide us as we settle into these next few moments that we're going to have together this afternoon. And so as you get settled, as you look around your space and you notice what you see, you might even say those objects aloud. You might notice that you want to move one thing from one place on the desk or beside you. But we're simply just calling ourselves into presence to this new space that we're gathering in together. And then when that feels complete, I'm going to invite you just to take a moment and still your gaze. And if it's helpful, you can close the eyes or just take a gaze downward. and take a moment to simply scan how you're showing up right now. How's my body at this moment as I'm seated in this chair or lying down or walking around and taking this in? How is my body? What's feeling really helpful about my body right now? What's maybe feeling not so pleasant? I'm just taking a moment to observe without any judgment. And then taking a moment to scan from the top of the mind and noticing what are you thinking about. And you might even notice that you're thinking about just this simple activity that we're doing here. But what's on the top of the mind? What thoughts are present? And once again, without any judgment of acknowledging what's present, give yourself an opportunity now just to take a moment and notice how your heart feels, right? Like what emotions are present for you on March 28th in this moment. Maybe even noticing something that you took in from this morning's conversation. How's your heart? And then as you land there, just give yourself an opportunity now just to scan your whole experience. Make connection with your breath, noting that it's showing up with you right here as you begin this next part of your day. It may be helpful to take a long breath in through the nose and out through the mouth. Sometimes a deep sigh is one of release, just to transition from one moment to the next. And then as you take that in, come into that question of, based on what I just observed about myself, what I know about how my body feels, how my mind feels, how my heart feels, based on what I know, how can I support myself? That may mean that you may take a few breaths. It may mean that you write down the thought that's on the top of the mind. It may mean that you shift your position or location wherever you're landing. And it may mean that you might add an activity once we leave this space today, but based on what you know about yourself, what's the best way to support yourself as we transition into our time together? And then when you're ready, give yourself an opportunity to take a few breaths. If the eyes are closed, open them back up and invite yourself back into the space. And so as we gather here today, I'm going to share my screen. Oh, hold on. Is it? There we go. Okay. So what we just did in this moment was what we called aspects of experience, right? And so whether you fully participated in the guiding, or maybe you took a moment to yourself to take care of something that you needed, it's that question of, how are you that we tend to ask. And many of us, when we are asked, how are you? We might say, I'm good. We might say, I'm great. One frequent thing that I hear a lot right now is, I'm tired, I'm exhausted, right? So we kind of give that answer of autopilot. And so what we just observed of ourselves, we're all parts of our experience as a human, as a being. And that was our physical body, right? How's my body feel right now? Maybe how does my body feel after I eat? How does my body feel from sitting? How does my body feel right now? What sensations are present? And then there's the mental, which is the mind body, which is, what's on the top of my mind? Is my mind really scattered? Is my mind really clear? Do I have many thoughts? Do I have one thought? Do I have no thoughts? But how's my mind? What's my mental state right now? And then we have our emotional body, which is our space of our heart. Like, what feelings are present? How am I experiencing right now? Am I experiencing feelings of grief or joy or excitement or embarrassment? Or, how is my heart, right? And then also noticing that there's tends to be more than one emotion or feeling that can be present at a time, right? And there's an equanimity. So there can be joy and sadness. There can be happiness and sadness. There can be pain. There can be many things at one time. And then there's the breath, which is, how's our energy, right? Like, how am I moving through my day, right? Like, am I feeling fatigued? Is my energy fairly scattered? Is my energy feeling steady? Am I feeling high energy? I got good rest last night, right? And then we have our intellect and our wisdom, which is that question that I offered up at the end of our time, or end of that guided experience, is like, based on what I know, right? Like, I'm my greatest teacher. I have a mind, I have a heart, I have a body, and I also have intelligence. And so based on what I know and what I observed, what can I do for myself? What's my next movement? And so as I introduce this activity, the purpose of it is, how can I land in my present moment with awareness of who I am and how I am? And so today's session that we're going to be moving into is this practice of moving out of that response of I'm good, or I'm okay, or I'm all right. But how can we really tap into the truth of who we are and how we are in any given moment, and let every moment be a new moment, right? Especially when we are moving into this conversation today around eating disorders, and how marginalized communities experience eating disorders, right? So before we move, I'm going to say, ask yourself, right? We're not really physically engaging in this moment, but ask yourself, how are you right now? And maybe there's a word that's on the screen that really names how you are, but definitely take care of yourself based on what you know as we engage and for the rest of this afternoon. Definitely also a practice that I encourage you to do throughout your day as well, when you move from moment to check in. And so during our time together, this session will really highlight diverse communities' experiences with eating disorders. And so there's a few intentions that I'd like to land here with the information that will be given, and then also the engagement with questions as well. So my work has been landing over the past 10 or so years with working specifically the Black community, but also marginalized communities around increasing health and well-being and wellness. And so it shows up in providing not just spaces to heighten awareness through contemplative practice and community building and education, but also how do we not just heighten awareness, but then we also take action based on what we know, not just for our individual selves, but also for our collective. And so what that means is, as we create more spaces for health disparity to decrease, specifically in marginalized communities, how do we take on the role for everyone, regardless of identity, to really tap in and to understand that simply because a marginalized community may experience life and well-being in a certain way, that it actually is a collective action that one may take to really address the roots of many of the problems and barriers that we're going to address today. So some of the intentions that we're going to land here are introducing the systematic inequalities faced by BIPOC, so Black, Indigenous people of color, and lower socioeconomic communities. We'll identify the root causes of eating disorders within these communities, as well as then move forward by understanding the benefits of a holistic approach of eating disorders. And holistic approach can mean many things. And so holistic by the sense of, what does it mean to not just listen to but the body, but the mind and the heart, and our awareness and our community. So how can we all work together to approach eating disorders? And then exploring practices to cultivate awareness, enhance communication, and build rapport with children and adolescents experiencing these specific behaviors. And then developing accessible skills to establish connection and identify resources to improve treatment plans. So as we navigate today, ways to engage. So I invite you to use the chat. So I know that our tech assistants are going to be monitoring the chat and taking questions for our Q&A that's going to take place at the end. And then also place comments, right? And so use reactions. If you're like, oh, that resonates, then, use Zoom in a way, feel like engaging. I know when we're in person, we might have the head nods or the thumbs or anything. So feel free to engage in ways that feel supportive to you. And then the next thing that we'll do is write down questions for Q&A. So if you just have them, if you're taking notes on a notepad, write down questions. We're also going to be doing an activity that I'll guide us through towards the end as well. And then I'm going to encourage at the end is to create an action plan. And so I'll leave some skills and some steps to do that as well. So as we move into our time together, let's identify, so what are historically marginalized communities? You know, we use that term very frequently. Sometimes I tend to use it. I tend like also just like to say, as a Black woman, I always name as marginalized communities. Like sometimes I'm like, oh, we might be the most marginalized communities, but what does that really, really, really mean? Understanding that there are so many different subsets of our communities and identities that experience a different way of being and a different lifestyle based on their identities and all the ways that identity might show up. So historically marginalized communities are groups who have been relegated to the lower or peripheral edge of society. And so that might mean many groups that, and some continue to be, denied full participation in mainstream cultural, social, political, and economic activities. Right. And so think about just the people that you have in your life, right? And noticing how can they participate in cultural, social, political, and economic activities based on their identity? And then also, how can they not participate? Where are the barriers there? And then marginalized communities tend to be impacted by inequity, either as an individual, a group, or community, as they experience institutional, structural, and systemic discrimination due to bias or racism and access to opportunity and resources pretty much on a daily basis. And so there can be one-off situations. And so there's times where, you know, you may experience more marginalization, but this is overall in general. But on a daily basis, who is experiencing these bias, this discrimination, usually on a daily basis? And so as we center marginalized communities during our conversation today, it's important to explore and really identify what demographics are classified within the groups that we land in, and then as well as the inception of social inequalities that are experienced by these groups. Like, when did they begin? What is the reason why they began? And so these groups that we're going to name as marginalized communities in this moment are our LGBTQ population, so lesbian, gay, bisexual, and transgender community, senior citizens, right? So really understanding that, you know, ageism is really a thing that causes discrimination in our country in this moment. Black, Indigenous people of color, so BIPOC, which you'll see throughout our presentation today. Military combat veterans, right? And so just thinking about, you know, the different behavioral health and lifestyles that are attributed, and then also a connection with military combat veterans. Persons of below average intelligence. And so this might be someone with special needs or a cognitive deficiency based on a diagnosis or a disorder. Hearing, visually, and physically challenged persons, right? So individuals that might have some type of, I sometimes tend not to say disability, but a varying ability or a different ability, somebody of diverse ability. Persons with a serious and persistent mental health, right? Someone that might have a diagnosis that, specifically if we're talking about our youth or kids, someone that might actually just have a mental illness that prevents them, right, from living life from the time that they wake up to the time that they go to bed, due to an inability to really connect with their environment, or having a behavior that might be seen as like ideal or normal, right? There might be a diverse behavior that we might not be aligned with our status quo. And then persons with cognitive impairments, right? So I want to name all of these, as these are all classified as marginalized communities, right? And so there might even be more to a list. for today, we're really going to be focusing on BIPOC, so Black, Indigenous people of color, and then those of lower socioeconomic statuses. And so I want to name with the lower economic, socioeconomic statuses is that 1 through 8 on this list, there's a higher number of lower socioeconomic statuses in these subsets, right? And so we're going to kind of place those together and kind of move our conversation centering them. And so one thing that's really important is as we are addressing, and we're going to be looking into the experience of marginalized communities, many localities, many of our areas, many of our institutions and our environments really struggle to identify which groups in particular are marginalized and why that's the case. Right. And it's like, why are these environments marginalized? Why is there potential disparity in access to resources? But sometimes it may be obvious with common examples of, hearing visually and physically challenged persons, or, some examples that we know that are related to marginalized communities are homelessness or impoverished, or, lack of resources to come into and to be a citizen of society. And so, but it can be really difficult to really tap into marginalized communities for various reasons, from technology, from location to proximity, and so forth. So developing and understanding how these specific groups on the screen are marginalized is really a necessary condition for our health system and for our institutions to really successfully engage and assist them in behavioral health in general. And so broad approaches to engagement, which we'll talk about later, financial assistance, and other programs may really fail to reach these communities if we're not actually identifying them as marginalized communities. So that's where the awareness comes in, is really understanding it's the who are marginalized communities, and also the why are we considering them marginalized, and then having an intention with producing programming and then also spaces for them. So let's go here. And so I want to land on the idea of what really centers marginalized communities in our country, right? So we are landing in Richmond, Virginia. Well, I'm landing in Richmond, Virginia. I'm sure you're spread throughout this state. But Virginia history, right, is really important to a lot of the work that I tend to do here in Richmond, and many of the people that really are addressing the root causes of many of the systemic inequalities that we do see for marginalized communities. And so as we introduce the history of Richmond, the first thing I want to introduce is just the fact that, Richmond, Virginia is the epicenter of our country's economic development system, right? And so that's tied to our wealth. And so the root of our economic system and access to wealth is really a factor of how we access, or both how we access resources, but also who is valued enough to even have resources, right? And so what's the ideal image of the American? What's an ideal image of an individual, or a youth, adult, a child, of a person? And so wealth is a measure of an individual's and a family's net worth, right? And so it's how we live in this world. And so as we discuss and bring in marginalized communities, it's important to understand that, our wealth and our value are very much tied to the resources and the experiences, both culturally, socially, personally, and then experientially, that we experience. And so it provides us with that pathway. And so wealth makes it easier for individuals specifically to seamlessly transition between whether it be jobs or movement to neighborhoods or access to resources, responding to emergency situations, and most importantly, meeting basic needs. And so it allows parents to pay for certain resources, to pay for food, to pay for education, prepare for economic stability. And it's also really important to be a measure of a family's future. And so we sometimes name, how does economic well-being and history and all of that tie into a youth's well-being, our own well-being? But it really is that the landscape of the way history has been created is that there's a map of what is ideal image and then what is not, or who is valued in society and who's not. So just briefly bringing in Richmond's history. So over 400 years ago, Richmond became the epicenter of our country's economic development system. And so it really created our body image, our family structure, and our socioeconomic status. And so as we name communities of value versus communities that may not have been valued, we land that it's the place where really freedom was taken, oppressive mindsets were really built. And if we think of around oppressive mindset, what does that look like? That means negative self-talk. That means valuing your mind, valuing your body, valuing your family. It means what's right and not right, what's good and not good, what's beautiful, what's not beautiful, what's pleasant, what's unpleasant. But creating a vast amount of energy during that time, centering here in Richmond, Virginia, it's really the place where the root of many physical, emotional, social, and economic health problems really began, and unfortunately still persist today. And that doesn't necessarily just adhere to Richmond. It doesn't necessarily just adhere to enslaved Africans in Richmond, but also every identity, and how we also view every identity, and what is seen as, once again, the ideal or the person in which we might be comparing ourselves to. And so as we understand what oppressive mindset and what that looks like, identifying the root causes of just behavioral health in general is really important. And so racial trauma, generational trauma, and historical trauma are the three ones that I really want to bring into our mindsets today, right? And the way that trauma really does show up into our environments. So as we understand both individual and collective experiences, trauma, systemic inequities, it's important to really acknowledge that the root causes of behavioral health in both BIPOC and lower socioeconomic societies. So even in 2023, the effects of our historical and generational experiences are evident, and not just BIPOC community, but the whole community, regardless of race, ethnicity, age, experience, background, proximity. So 1 in 5 Americans are diagnosed with a mental health disorder. And while communities of color have, higher numbers of rates of mental health, they're similar to majority culture, meaning that they're similar in number of them, similar in number, but they're also higher in number of not being addressed or going on longer due to the socioeconomic and societal and systematic inequities that are based on and derived from years of generational and historical and racial trauma that shows up in our systemic in our systems. And so it's important here to acknowledge that, these might show up, right, as mental health issues, as employment and education, as homelessness and housing, as racism, and then also barriers of healthcare, which we kind of really tapped on most this morning. And so if we think about history and traumatic events, this chart right here basically just shows how, what are some root causes of traumatic events, or what are some, what's the root cause, which I'm going to name as individual and collective trauma, to various behavioral disorders or behavioral health, and then as well as how does that show up. And so when a traumatic event happens, right, both known and unknown, there's emotional, psychological, or physiological distress. And then there goes, and when that happens, there is a loss of security and need for self-protection. right? And so loss of security can show up in a lot of ways. It may mean that it shows up in not feeling safe in our body, right? It may mean not feeling safe in our family unit or our support system. It may mean that there's a need for self-protection. So needing to control what's happening in my world because I can't control my environment. It may mean that there's a loss of safety, like being able to use and speak up for myself or ask for my needs. Right. So there's many different ways that loss of security and needs for self-protection might show up. And then another thing that emotional, psychological, and physiological distress, which you can see the two arrows on the side, is that there's a lack or an increase of appetite many times, right? When we don't feel safe in our bodies, we either maybe withdraw from eating or we may eat a lot. We may have low self-esteem because we're comparing ourselves to the way that we should be, right? To the way that we want to feel. There might be sleep disruption. There might be anxiety or depression, right? So the vulnerabilities that one might experience that continues to create a space of needing to protect myself from anxious feelings, needing to protect myself from the scattered thoughts, needing to protect myself from this lack of value or this lack of worth. And then as we continue to name on the other side, so there's short-term relief, right? So due to distraction from trauma, the distress cycle continues long-term. And so this is just kind of really understanding, what does it look like once a traumatic event happens, right? And how does one maybe show up? And so as we continue to tunnel in, we land at use of disordered eating behavior, right? And so one thing that I think is important to name as we land here, most of the information that I'll land on today is really addressing like behavioral health and the subset of eating disorders based on experiencing racial, generational, or historical trauma that's mostly present in marginalized communities. And one thing, I was in conversation with a colleague not too long ago, and one person said, like, I wonder what, not everybody experiences racial trauma, right? Or not everybody is experiencing generational trauma, but the truth is, right? So the racial trauma that we have experienced collectively, the system that we've created that values one identity over the other, the understanding of generational trauma that's not just passed down between families, but generational trauma that's passed down culturally, both in our systems and our families, and then our school systems, health systems, families, and then our historical trauma. How are we valuing identities? So all of that is not just present for one identity, right? We are all collectively affected by it because it affects the way that we look at our world. And so we'll name today and go through a bit of a framework of equity, but our experience really directs our lens on how we may treat or address or see or observe or witness or respond. It really determines how we're in relationship with an individual that's in front of us, whether we're working with them specifically with eating disorders, right? Or something just behavioral health in general, or maybe if it's lifestyle. So just thinking about that and landing there, as we dive into marginalized communities' experiences, it's important to acknowledge that the first thing that is going to be invited in is a sense of awareness through the knowledge of what it may look like. Because the one thing that we know is, even though people of color, especially Black Americans, and those in the lower socioeconomic realm, are significantly less likely or have similar numbers of eating disorders, but are significantly less likely to receive help for eating issues, despite suffering from them, whether it's in silence in comparison to their white counterparts, really because it looks different based on culture and these traumas that are mentioned here on the screen. Okay. Okay. So systematic inequalities, most common inequalities faced by BIPOC and lower socioeconomic economies, communities, wage inequality. So I'm just these are just ones that I've already listed. I just want to name them. And so you have them as a list. So wage inequality, wealth gap. So the wealth gap between a lower socioeconomic and higher socioeconomic is pretty expansive in our country. And so usually in 2016, the wealth gap, which creates the access to resources, proximity, education, all of that was at a deficit of at least like a 57%, right? So the wealth gap is huge between these communities. And then also health insurance, right? Access to health insurance is one huge barrier when it comes to marginalized communities. So either we're not making it, or these communities aren't making it to the doctors, right? Or to the treatment providers due to not actually having those socioeconomic resources, or maybe just not even having the community or of support there. And then homelessness, right? And so just thinking about what homelessness looks like, specifically when it comes to behavioral health and eating disorders, right? So there's lack of food, there's lack of access to food, there's even lack of security. And so homelessness is one for me that when I look at, is it's that the complete example of like the lack of or the loss of security or feeling safe in my body, right? Or feeling safe in one's body, because we're in that survival mode of trying to create that safe space in the body, right? So homelessness is a systematic inequality, residential segregation. So where one may live based on their income, based on their race, based on the way that that cities are set up, right? So we know that residential segregation can also land into what we want to know as food insecurity and access. And so we'll get into that a little bit more, but where are the grocery stores? Right? So eating might look a bit different. Like where are the grocery stores? Where are not the grocery stores? What food access is available? Right? Is it more nutritional foods, or is it foods that might look a little that are higher on the processed foods? And racial gaps in education, which is huge, right? So education in academics, one thing that we know is by the time that a young male or a young Black male or a young person of color, this is for both Latinx and then also Black males, by the age or by the 5th grade, they are already 32% behind their white counterparts in school. And so when we think about education, right, when we think about what it means to education around health, education around behavioral resources, education in all of its form, both academic, both mental and behavioral health, and then education of just like common sense and like being out in society. We have those, right? But what is the gap in education that one may have to even understand what an eating disorder might actually be too? Racial discrimination, right? And so having the access to be in specific environments or institutions, even being addressed or observed or witnessed in ways that are of value, right? So we know that racial discrimination, both in schools, both in hospitals, both in educational systems, and as well as our general community, happens more frequently than not in these communities. And so then child poverty is something that we want to name as well, right? And so I think about this in my work within the school systems, is watching our youth be really like breadwinners in their family, right? And that seems like a big thing, but really being the ones that are trying to to make money for the family, or assist parents with making money for the family to take care of little children for their siblings and things like that. So just thinking about, these are all different ways in which one may, in which our system sheds light on, but then also affects marginalized communities. And so those were just a few examples, but but they show up in many, many ways. And so with those inequalities, eating disorders are more common than we think, right? And so not are just they more common than we think, they tend to be a bit more specific as well, specifically around a cultural way. And so we've landed at the common types of eating disorders. And so anorexia nervosa, we've got binge eating bulimia, the ARFID, avoidant restrictive food intake disorder, and then other specified feeding or eating disorders. And so the ones that are most common in marginalized communities are then binge eating, which is, when someone frequently consumes large amounts of food and feels out of control, like preventing them from stopping. And so then we've got bulimia, which is when they eat large amounts of food and then they purge by forcing themselves to vomit, maybe using laxatives, compulsive exercising, or diuretic use. And so those are the two that might name as the most common in the Black community. But then we land at the avoidant restrictive food intake disorder. And I know earlier I was mentioning that it's not tied to body image, which is so important to acknowledge, because it's really characterized by the decrease in a variety and quantity of food, right? Which really makes a lot of sense, because then it leads to nutritional deficits and deficiencies. And so that's one that we might actually see a lot within within marginalized communities, both in a way that's conscious and unconscious, right? Or both with also having the understanding that due to systematic inequalities, that's one that may show up. And so when we're not eating enough, they're sensory avoidant. When we're not eating enough, or they're sensory avoidant, or there's a lower appetite, or there's traumatic events, that's what we might actually see. And so it's like, are we, and how can we look for that when it comes to working with marginalized communities? And then there's OSFED, so other specified feeding or eating disorders. As we name there, it's important to bring in the idea of, once again, disordered eating, because it might look different. And so when we think about the history of eating within cultures, we bring in the fact that eating disorders are rooted in the system of racism that was designed to create separation between Black bodies and white bodies. Right. I think that's something that we really, it's important to kind of really bring that to the forefront, because it goes back to that, what's seen as good and not good, right? What's seen as valued and not valued. What's the ideal image and what's not the ideal image. And so it's important, as we move into our conversation, really talking about, what's the standard of comparison? And many times the standard of comparison could be our white supremacist standard, right? And it's that white male is the ideal image, right? And then we kind of move back and back and beyond that. And so as we do this, even with looking in communities that are not considered marginalized, and what eating disorders look into that, it's like, what are the root causes of them? And usually tied to some type of trauma that takes us outside of our body and our experience with ourselves, that doesn't see ourselves as whole, and sees ourselves as moving into a different image. And so the condition in which people are born, grow, live, work, and age have a profound effect on how healthy they can be. And so this is where we're going to get into what are the root causes of disordered eating, right? So, and by disordered eating, different from our what a normal nutritious eating habit and eating diet may be. And so let's look at social and cultural barriers. So I've broken them up: social, cultural barriers, personal barriers, and institutional barriers. And these are all spaces in which we name when we talk about equity. And then we talk about how do we look at what lenses are we looking through, right? So I'm actually going to start over here with personal barriers. So personal barriers, what are some of the root causes? Unworthiness, negative self-talk, right? So how am I talking to myself, right? How am I affirming myself? Am I receiving affirmation from others, whether it's present or not? One thing that I think is really important to name when it comes to worthiness and value, sometimes is many tied to what does it look like how am I feeling, right? And then how do I talk to myself? How do I express towards myself? Feelings of rejection can usually many times be a personal barrier that then also emphasizes and then also leads to disordered eating. So feeling like that might be not be good enough. And so one thing specifically that we might look for when it comes to working with our youth is a youth in academic environment, specifically ones that might be different in diversity. And so having youth that are in environments that might be rigorous, or feeling the need to strive, or feeling the need that they're not good enough. And so feelings of rejection can then also cause disordered eating. Self-judgment is one that is really important to acknowledge. And then also self-esteem. So how does one feel about themselves? And then we move to social and cultural barriers. What cultural beliefs does one have? And so this is where I kind of really want to tap into marginalized communities specifically in general too. And so when we talk about cultural beliefs, I think truly around what do we think is beautiful, right? What do we think is healthy? And so if you look at images of specifically brown and Black women and brown and Black kids, I've been at my family reunions where, my grandma might say, "Oh, you're too skinny," right? And I'm like, "Oh, what am I supposed to be, like, larger? Or, what's wrong with my size?" But thinking about cultural beliefs, specifically in marginalized communities or BIPOC communities, is that larger bodies are beautiful, right? And so, or it may be that, or the way that one looks in clothes. It may be the understanding the identity that when we see people of color that are experiencing disordered eating, many times it's not that they're really skinny. It might actually be that they are in a larger body. And so then we might not actually think that they have a disordered eating. And so it's kind of really kind of naming what are we looking for, and are we having an understanding of beliefs when it comes to navigating and identifying. And so thinking about ideal images, what's an ideal image within these communities, right? And so there may be the image of we like to say, in some communities, specifically in when we look at our kids, is who has a different hip to waist ratio, right? So we look at hip to waist ratio with body. And so, or who has when we think about our kids, who's more muscular or athletic, right? So thinking about images in which we really accept, and really images that we really understand or promote as good, but also realizing that they might be different from our mainstream status quo. And then media intake, I think, is really important to really understand, because listening to what does music say? I think one thing that's really important culturally is that, there's a lot of music that not just hypersexualizes body and body image, but it also engages us in conversation around, body parts and the size of body parts and what's good and what's not, and what's good and what's valued versus what might not be as adored. And so really understanding that these cultural norms that have been created over our generations are ones that need to be at the forefront when it comes to working with individuals, specifically in Black and Brown communities or lower socioeconomic statuses, because the question goes a bit deeper of who are we really working to support, or what are we like looking for? And so the last one, when it comes to institutional barriers, food insecurity and access. And so for these, I really invite in that there are many institutional barriers that name for disordered eating when it comes to, once again, where are grocery stores located based on the way that cities are set up. If you think that there are bodegas, right? So there's some bodegas, there's convenience stores many times. I know specifically here in the East End of Richmond, it has one of the, or it has historically has had and been one of the areas with highest health disparity, right? But didn't have a grocery store for a really long time. And so now there's a grocery store, yet really understanding that there wasn't necessarily access for fruits and vegetables and nutritional eating. And so that the disordered eating is just like not necessarily eating that. Or maybe when it talks about food access due to the wealth gap, it's important to understand that families who are trying to feed multiple kids as well, right, without having the access to funding and resources to truly feed families, then might look like having meals that are higher in starch or higher in fiber, right? So they last a lot longer. And so thinking about kind of what does culture really look like and how does it play a role in the way that we are looking at what eating disorders look like, but also how is our institutional barriers really playing a role on how we are even creating spaces for food security to really happen, or going back to social and cultural barriers, what does it look like to really create a space where we really begin to see and address diverse body images and diverse cultures? So then we can kind of really look at eating disorders along with disordered eating and the roots of their causes. So as we kind of name with that, I'd like to bring in a different look to a holistic approach to eating disorders. And so these 4 keys come from SAMHSA's 6 key points of the trauma-informed approach. And so these are derived from them as we are really looking at disordered eating as with trauma as a root cause. And so the first one, as we approach, we want to reestablish safety and support. So really in our environments, it's important for us to not just reestablish safety and support in our connection with the individuals that we're working with, but how can we invite these individuals to reestablish safety and support within their own bodies? Right. So I'll be speaking to how we can directly work, but then how can we cultivate and empower this with the individuals that we're working with, both through awareness, through communication, and then also providing resources. And so the second one is how can we develop emotional regulation skills? And so this one's really important because developing emotional regulation skills for someone who is then holding the space or maybe addressing or witnessing disordered eating is important and key because the ability, sometimes the capacity to then manage, the capacity to manage what information is being shared may and has the opportunity to be either overwhelming and or the capacity might actually just not be there. Right. And so if we're working with someone that's having disordered eating due to personal, social, and cultural and institutional challenges, as a practitioner or someone that's providing service or professional support, that's important that we then arm and resource ourselves by developing emotional regulation skills. It is then important to encourage and to create space and resources for the person experiencing disordered eating to then develop emotional regulation skills. And so with that, we'll go into what that might look like, but how do I manage my emotions? How do I address named conscious and unconscious traumas in my life? How do I address bias that are being perceived around me? And then identifying resources. So really being able to create a catalog or a list of resources that one may be able to present to better support the individual that you are then centering. And then enhancing resilience. And so this one is really specifically for the individual that is experiencing it. How can we enhance the resilience of this individual? Because the definition that I tend to use when it comes to resilience, it's not that we meet challenge after challenge after challenge and we get really good at meeting challenges, right? It's our ability to enhance our capacity to regulate ourselves in safe and supported ways when challenges arise. So we don't necessarily stay in the trauma or that feeling of needing to control, but we get into a space where we feel supported and safe in our body to manage what is happening around us. And so as we know that, body shape and symptoms of all behavioral health, but specifically disordered eating may show up differently in Black bodies, it's important to acknowledge that if we explore practices to cultivate awareness and enhance communication and build rapport, then we have an opportunity to really then to start really addressing them rather than addressing them for long-term care rather than avoid or let the disorder go untreated. So that's where this concept of mindfulness comes in. And so I always say that I get into this field of really taking mindfulness from being a science, but really into a way of life, right? And so same, we think that we have to breathe, we have to sit still, we have to do this thing, but mindfulness really is an opportunity for us to pay attention to the present moment and noticing thoughts, feelings, bodily sensations, mood, all with an attitude of curiosity, compassion, and acceptance. And so with that, it's really simply being aware for us to really take in and meet our environment and the people that we're in communication with and ourselves in real ways. And the ways that we, the benefits of, being more mindful, being more present is that, we're self-aware. And it's really checking in, like, what do I know? Who am I? But it then goes into emotional balance, right? And so emotional balance is tied to our ability to be compassionate and curious as we work with marginalized communities in their experiences, but how can we also balance our emotions in a way that empowers us also to then be more into social awareness and be more into social activation and be more into social advocacy around what we think of or what our research really shares with us about eating disorders, and then taking a broader lens to it. And then relationship management. It's that's the part where how do I then create a supportive space in my engagement with those that I come in contact with? It's really one thing that my name is like community-centered or client-centered care. Like, how do I look at each individual and how do I create a space for each individual to feel seen, felt, and heard in their experience? And how can I not just observe what's happening with them versus like what I already know, so I can really see clearly how I can be of support, not just within that engagement, but then also holistically outside and then within that community. And so some ways that we'll start with ourselves, which is so important. Our relationship with ourselves is the relationship that tends to be our marker for other relationships. And so as we work with individuals, and really see and be in relationship with those that may be in marginalized communities, it's important that we take time of ourselves. We all know too much around burnout, compassion fatigue. We all, you know, stress, right? PTSD, all of the things that we might experience as we create space and we hold space, specifically in the behavioral health field. And so the practices that we encourage is like taking a moment to simply observe. How does one take in their environment? Take a moment to observe how you're feeling. That's similar to what we did at the very beginning, right? So when engaging with each person individually, going in with a new concept, with a new lens, with a fresh beginner's mind, with yourself first is important, so you can then be in communication and be in awareness of what's actually happening in front of us. And so taking a moment to observe. And so, like I said, that might look like a mindful moment. It might look like taking a breath. It might look like just a gentle check-in with the mind and the body. And then being curious and asking, right? So being curious about what shows up for yourself. And so that's really important as a self practice when it comes to expanding our lens and creating spaces where we are engaging with others, is being curious and asking, like, what's happening with me? What's causing what's happening with me? What's my response and why? How do I feel? And creating that space of vulnerability that's really present for us. And then acknowledging and acting. And so acknowledging and acting is a part where we land at really and truly caring for ourselves by acknowledging the moments when we feel overwhelmed, acknowledging the moments when we feel happy or sad, acknowledging the moments when we feel joyful, acknowledging the moments when we just don't know the answer, right? Or acknowledging the moments when we do know the answer, but acknowledging the wide range of experience that's happening and then taking a moment to act on it. So taking that practice for checking in with ourselves as one moves into relationship with another is key. And so the taking care of others opens up this concept of what we call mindful communication, right? And so with the information that we know, with shifting what disordered eating may look like in various communities, it's important for us to then clear to arrive. So these are 3 practices that one may use to be in communication and conversation with another. And so it's letting go of what we know to then fully arrive in conversation. And so I always encourage, yes, this is something to practice when it comes to, this is something to practice when it comes to yourself and your family, your environment, your workspace, any communities that you're involved in, to really shift what it means to come in with a beginner's mind. And so the 3 steps are clearing to arrive, mindful talk, and then of course, active listening. And so clearing to arrive is that place of taking that moment. It's clearing any preconceived notions or bias that one may have, specifically in the sense of what causes behavioral health, why it's there, what causes eating disorder, why it's present, but seeing if one can clear to arrive that. mindful talk, using awareness, feedback, and candor to be in real connection. So really taking time to talk to those that are in front of us, asking the question, get curious when you're working one-to-one with youth and maybe their parents. And I think some questions, it could be like, how is your eating? What did you have for dinner? What are your favorite things to eat? Right? Like, and really being open to what's coming. Why are these your favorite things? Who's feeding you? Are you cooking your meals? Why do you appreciate this body image? Really getting to understand culture and social, and then also the root of why those are present is really important. And then in taking that time to actively listen to what comes up when you're in conversation with those that are around you. And so as we're really looking at the root causes, I like to introduce the idea of radical self-care, right? And so radical self-care is really arising from or going to the root of something that is basic, right? Or getting back to the basics of things. And so we know that BIPOC and lower socioeconomic status individuals, teenagers have about 50% more likelihood than white teens to present bulimic behaviors like binge eating, purging, and binge eating, purging. But they're less likely than their white counterparts to be asked by a doctor about their eating disorder, right? And they're also less likely, not just by their doctor, but by their friends or their family or their parents, their teachers, but people in their spheres, because the education that they're persisting is just not necessarily there right now for many reasons. And one of them also being research as well. And so as we talk about getting to the root, it's important that when we are addressing that, we want to get to the root of what's happening. And so that's why we stay curious. And so the self-care part is the practice of taking an active role in protecting one's own overall well-being and happiness, specifically during periods of stress. And so how can we create a relationship that centers radical self-care in our institutions and in our relationships, so that we really can see what individuals are moving towards. And so these are 6 ways, 6 types of self-care that one may look for when they are working with a youth. So looking at their physiological self-care, their ability, like their safety and stability that's in their home environment or around their space, looking at their desire and their ability, their desire and their feelings around social and belonging, right? So when we don't feel like we belong, or we don't feel like we are around that social supportive space, that's when these disordered eatings maybe show up. Esteem and ego. What's the how do I feel right now about myself? How does my family feel right now? And then self-actualization is that space of living in optimal well-being, of knowing ourselves. But as we create these environments and addressing, these are the things that we really want to tap into. It's not just around the physical, what's being eating, but how do you feel? How are you experiencing? Are you feeling cared for? Are you feeling supported? And asking questions that really center the 6 types of self-care. And so then we go, what can we do? So mindful-based restorative practices, these are very, in a moment I would name as, things that we can just do solely in my own world, in my own institution, right? And so that would be, of course, really education. So offering education around eating disorders or disordered eating. What does it look like? That can be the pamphlets, that can be groups, that can be panels, but really introducing that to the environment. At my school at MLK, we have a group that discusses eating disorders. And so at MLK, we are predominantly a BIPOC community. I think we're 3%, 97% BIPOC community. And so with that, you know, it wasn't something initially, I would say, that we would have a support group for that. But I have a mindfulness room in this space, and we had probably, I would probably say, at least 2 to 3 students every single month that would come to me and talk to me about eating, right? Whether it was they, you know, they didn't eat breakfast because they didn't want to get fat, right? Or they binged on, you know, they didn't eat vegetables, but they ate their fruit, they ate their potato chips and their Takis and their sodas and stuff, right? But that was the only thing that they ate. So the nutritional deficiency, and they would just eat that. Many of our students, they skip lunch, right? They don't like the lunch food because it's not something, they're sensory adverse to it. So they would skip lunch. So one thing that I would have to start doing is starting to bring stuff for them to eat and then introduce it to them slowly. Because it wasn't that they had an eating disorder, right? It was really disordered eating based on their lifestyles and based on their access to foods. And then also one thing that's really important that we talked about earlier, when it comes to education, what is seen as beautiful and unbeautiful, pretty and unpretty, right? So social media played a big role and continues to play a big role in what it looks like. If we have our videos and our music videos, and we have what it looks like in our family, if someone calls you like nicknames like Chunky Monkey or Chubby Cheeks, right? Those things are things that we just kind of move away from. And so education around what it looks like to have healthier eating styles in a very normalized way is so important for our youth to have as they build and create their diets. Intuitive eating, that's one thing that is really important that I encourage you all to suggest, is building healthy relationships with food by including journaling and mindful eating. And so taking youth through ways to really like understand their food and their experience with it. And then journaling what it feels like to eat it, journaling what it feels like what did it smell like? What did it taste like? How did you feel before it? How did you feel after it? But taking that step-by-step time to really understand an experience with one's food is important. Because I would also say too, we do a thing called mindful eating, and we do it all together, and we discuss how we feel before and after. Before we eat certain foods, specifically, I'll say like a vegetable and all those things, because they didn't necessarily have access to them. Ew, I don't want it. I don't like it. We do mindful eating. We talk about it. We taste it. We smell it. There's a completely different relationship to it. But then what we'll talk about next is, as I gain or navigate into what does it look like if they like it, but they don't have access to it based on where they live or their resources, what resources then does one have to then create a space to provide access? Who do I work with? Who do we work with and partner with? Promoting body inclusion. So creating spaces where you're engaging in self-acceptance practices and affirmations. Prior to the session from this morning, really landed on some really good affirmations that I think work really well. I am enough. I am beautiful. I am here. I am kind. I'm seen. I am heard. I am felt. But body inclusion, really accepting ourselves for who we are, not just for body shape, but really accepting who we are in our bodies, whether it's from sexual orientation or gender identity or race or ethnicity. How can we create environments that really promote body inclusion and identity inclusion? And then creating BIPOC-centered support groups. So creating virtual or in-person groups that center reimagining and shifting relationship with our bodies and our body images. Like, what does that look like? So there can create that practice of really being in communication around one's experience in a space that represents individuals or who they are. So if it's a youth group for LGBTQIA, if it's a group for seniors, right? If it's a group for BIPOC, but really allowing ourselves to kind of name, what does that look like? Okay. And so as you do this, advocating for lower cost treatments and food insecurity, these are things that I invite you all to do as you advocate and build your network when in support of these communities. That's one thing that will be key, because then it creates that pathway to healthcare, but also access to food. So one doesn't have to, or one doesn't feel like they need, they don't feel that insecurity. Identifying roles, responsibilities, and resources based on your own experience. So who are you? What are your responsibilities in the environment that you are, and what resources can you use to address both the traumas that we have that are maybe causing disordered eating, or behavioral health in general based on the institutions you're in. Increasing access to resources to include extracurricular activities that include meditation, mindfulness, mentor programs, dance studios, and other places in our community. This is important because these spaces then create self-empowerment and then community support, right? There are different ways of getting people engaged and feeling in their bodies. Develop small groups that center the experience of marginalized communities. And then the one thing is practice. Continue practice active listening, mindful talk, and practice understanding your own lens, right? I think that is key. So this is a framework that's from one of my teachers out in California. And it's really like, how do I view the world, right? How does that inform my values, beliefs, and assumptions with environments that I'm working in, or just in general? Determine my interactions, expectations of others. And then how can I use this information to impact the outcomes that I experience or who I am experiencing? And so our practice over here to the right is, we're breaking conditioning of what we may think that eating disorders might look like, right? But also breaking our conditioning, how we address them. So this is a way to heighten awareness based on our own individual experiences. And so we do this in opportunities for us to grow, right? And so they say the only way out is in. So it all really starts with us. How can I really understand how I'm viewing the world, or how I'm viewing behavioral health? And so these right here are the 4 different subsets in which we might, these are the 4 systems of I'll name with of our society and how we might break and create more equitable spaces. And so the first one is personal, right? So these are ones that you might use either for yourself, or you can use them when you're working with somebody. What feelings or beliefs and values are present? That's the question to ask, because that's the root of why our behavior shows up. Like, what feelings and beliefs and values are present for me in this moment? Interpersonal, what language, actions, and behaviors do I use? How do I engage with other people? If someone shares with me that they are eating a lot because they have lack of food, right? They eat a lot and they're binge eating, right? What behavior, how do I address that, right? What resources do I find? Do I hear it with compassion, or do I make a judgment towards it? Right. So it's really kind of understanding how do we engage as we create these spaces of growth and awareness. Societal, what do I believe to be normal, right, and good? Like, what do I believe as I am in relationship with another? What society and cultural beliefs do I have? Right. Also to the ones that you're working with, our youth and adolescents, their parents, what do they believe to be normal, right, and good based on their experience and identity, right? Institutional, what policies, rules, practices, and procedures happen around me, right? How does my institution set up? How is insurance set up? Who do we see the most with? Who do we create groups for? How do we create groups? Right? So really kind of allowing ourselves to really begin to move into this collective self-care model and encourage those that we work with to do the same. And so this is a practice that I'll send you home with today, naming your identity. So who are you? From where do you come? And list all of your identities. right? So these really tap into that space of awareness. Name the roles that you hold. How does your identity show up in your relationships? What are your affiliate organizations, careers, and environments? And where do you engage? And then name your personal responsibility. Like, what's your purpose? What resources do you have to achieve your purpose, right? So we're here talking about marginalized communities, experiences, and eating disorders. How do we address disordered eating and eating disorders? I always attribute that, tapping into all of the both racial, generational, and historical trauma that we have, regardless of how it shows up, seems like a very big, it seems like a big task to have, right? So it's not that we're meant to tackle all of that. We're meant to understand who we are, name the roles that we hold when it comes to how do we create a supportive, safe, and equitable space for individuals, specifically in this realm, that are experiencing disordered eating or eating disorders based on what we know about the social inequalities that are present. And then what resources do we have to then achieve this opportunity in this space? And so then once you complete that, you'll get these slides. You can name one thing that you can do to support them at that minute, because when you know what to look for and what resources are available, you have an opportunity to start in the right direction. So trusting that you have the skills, the tools, and the support to do that. These are some collective care practices that I invite everyone to get involved in when it comes to working with your colleagues, when it comes to really tackling and addressing these experiences in real ways. Take a moment to really acknowledge what's present when it comes to the behavioral health field, specifically with this topic. Share responsibility. So gather with individuals to share their collective responsibility. Gather with the families that you're working with. Gather with the providers and the service environments that you're working with. Gather with the youth. Talk to them, right? They are huge advocates of wanting to create a world in which they feel more safe and secure, and there's more diverse inclusion available. And so creating that shared responsibility, mindfully communicating with all about the truths and the realness of the root causes of what's taking place, get clear and creative, and seek resources, right? So there are many resources, ones that are already present and ones that we might actually create. So this last slide, care is not just about surviving day to day, but enabling others and ourselves to grow, sometimes by facing difficulty, but always by supporting each other with radical love. And so as we kind of take the narratives of today, the one thing that I really want to leave us with is that, poverty and food insufficiency play a huge role in a lot of the things that we're talking about, and of course, we know that there's a lack of, medical support. We know all of those things, but what does it look like for us to really work together to create spaces where we're really addressing the root causes? And so this means that cultural competence is really crucial to really see people, to really love on people, to really create spaces that center their experiences. And so as we continue to address some of these behavioral health challenges that see show up, many of them, of course, always land at having a root cause of some type of trauma. And so always taking that cultural competency in hand as you address. And I always land here with that. We're trying to create a world in which we're all thriving and where we're not surviving. And so thriving is our goal. And that means that we're really tackling into that concept of well-being and wellness in each of our engagements. So this is my contact information. I will land at that. I will, stop share and hand it over. Yeah.
If anyone has a question for Ashley, you can go ahead and either raise your hands or unmute yourself and go ahead and ask it now. even in a virtual room, people are afraid to raise their hands or speak up. It's okay.
I just want to say this was overall a great, great presentation. And I like that you mentioned like the importance of being culturally competent and also the importance of understanding systematic issues and inequalities, and also the problems with homelessness and food insecurities, those the social economic status and the area of segregation, like all of those different things, how they align and connect with food disorders, food eating disorders, and people of from BIPOC communities. So I thought this was a very great, great presentation. So thank you for sharing your information and knowledge with us. What would you consider like to address, sorry, to address food inequalities and homelessness within our community? What will be your take? Is it addressing it at a macro level standpoint, like with policy changes?
Yeah, so I think that's where, it really depends on who you are, right? So this is for everyone. That's where that question of like, what's my role, right? So some of us are going to be addressing it on the micro levels, and some of us are going to be addressing it on the macro levels. And so if you're closer to the micro levels and that's closer to where your resources are, food insecurities for someone that might be in access, it might look like partnering with a local urban garden, right, to provide access to foods. We have tons here in Richmond that are always offering up food, right? It might look like finding resources for transportation. It might look like creating spaces where there's more, you find the spaces where food vouchers are offered. But you also think of food insecurity, it's not just lower socioeconomic, well, it's not just BIPOC communities or urban areas. Thinking about even like the college student or like the adolescent that just might not have those resources, what does it look like to create an opportunity for them to apply for food stamps, right? Or what resources does their university have? So those are micro, depending on who you are and where you are, those are the micro things. How can you address food access in the relationship that you're seeing, right? I frequently think about my college students that, work out all the time, right? But don't have access to food all the time if they're not like on a meal plan, right? And so, they're eating protein, but there's a disordered eating that's happening there, right? And so how can you increase access to food for these individuals based on their experience? When it comes to macro, if you're working in the institution, if you're an administrator, what does it look like to then to be finding ways to decrease the wealth gap, to finding ways to increase economic opportunities, finding ways to place bills for understanding taxes or more tax return, right? So the wealthiest get the highest tax returns, but what are we advocating for to decrease the wealth gap at a macro level? So then it's not necessarily the food access that is really the root of it. It's the access to wealth to then get the food. And then there's a little bit more layer. So it really depends on where you're centered.
Sounds good. Thank you.
Yeah, good question.
Any other questions from the audience? Got a lot of really great comments there in the chat, Ashley, so make sure you check that out. Okay, so I am going to, there we go. You're on, Nia.
Thank you, Ashley. I am so grateful for your presentation. You know that. But I am particularly grateful of the way that you talked about people of color and ways that we can better support treatment and what treatment integration looks like and how that can flow a little bit better than it has been. And in our conversations, you and I have talked about next steps, right? What is a possibility, or like what can we do to integrate mindfulness or body awareness into substance use treatment and practice overall?
Yeah. And so I would say for integration as someone that's in providing, right? Getting really good at your own self-awareness practices. Like, I'm just going to start with that, right? Like really tapping into understanding where bias are. What's your own relationship with both disordered eating and substance abuse? Because one thing that I do name, and I only speak from my experience specifically as a Black woman, but I'm a Black woman in wellness. And, you know, I definitely notice my ability and my capacity of disordered eating and how that then leads me either to substances or, you know, disordered weight loss, like all of the things, right? And so as the person that's delivering, and I'm like, what, the expert, you know, what we might call ourselves, I have to navigate like, oh, how do I like land in all of this? When someone comments on my body size, how do I respond to that? Right. And so these are things, of course, yes, we can only be our best provider by being our best selves and really understanding how both eating disorders and substance abuse shows up for us and being honest about it. And once again, those mindfulness concepts in an accepting, non-judgmental, and compassionate way, and getting really resilient around how we do it. And so I want to name that. I think that's really important as we create these spaces. But then when it comes to how do we integrate these practices, groups in which people are not just, so small groups, right? So mind body practice, I want to name those. There's three: mind body medicine, mind body practices. And that can look a lot of different ways. That can look like mindfulness, it can look like meditation, it can look like dancing or somatic embodiment practices. Like getting people in their bodies is key. And then the second one, creative expression, right? Creative expression, because trauma manifests in behavioral health shifts, right? Behavioral health disorders. And so the practice is, how do you get that trauma out? How do you release it? Right? So there's one place to be aware of it. And then you have the creative expression of releasing it. That could be writing, that can be journaling, that can be dancing, that can be moving, that can be singing, that can be, you know, how do you create spaces where creative expression is then being able to explored? And then the third is community and group support, right? So how can you create communities that represent the individuals that are showing up in it? And that could be race, ethnicity, age. I'm not just saying like a BIPOC only group, but like, how do you create a community of support where everyone understands that they're just trying to get to know themselves, right? And it's consistently meeting, but creating that, led and facilitated by someone that is doing that awareness work. So we're not going in fixing the situation, but we're going in just holding space for whatever trauma is there that is manifesting to be addressed, to be seen, and then to be moved out. Yeah.
I can't wait to hear more about this. You're going to be at the Research to Recovery Conference next month, and I cannot wait to hear more about it. So we're on our break time now. And I just had to get my question in. Please come back at 2:45.
Thanks.
Thank you again, Ashley.
No, thank you. It was so good to see you.
You too. Okay, welcome back. So we are at the end of the day, and it feels like time has gone by. I will now introduce our last presenter, Dr. Lauren Magruder. Dr. Lauren Magruder is the Executive Director at Veritas Collaborative Center in Richmond, Virginia. Dr. Magruder received a PhD in Counselor Education and Supervision from Walden University in 2021. She received her Master's of Arts in Education Specialist degrees in Clinical Mental Health Counseling from James Madison University. Dr. Magruder previously served as the Clinical Director at the Richmond Center. She has a passion for working with the BIPOC community, as well as training and supervising therapists. Welcome, Dr. Magruder.
Hello, how are you? All
Hi.
right. I am going to share my screen. Can everyone see that? Or at least some head nods.
You are sharing your entire display, including your speaker notes in the next slide.
Gotcha. Let me look at the other one. Sorry, I have two screens, so I have to figure that out. Give me 1 second. All right, well, I'm gonna talk while I change my screen. So thank you for the introduction. You guys should have a copy of the slides as well. And just with the introduction, I wanted to kind of add this caveat that I am pretty pregnant right now. And so if I take a drink of water or I sound out of breath, I promise I'm okay over here, but I just wanted to let you guys know that so you don't think, or if anything happens, I just want you to know what's going on. All right, let's see. Thank you, thank you. All right, I might need some help because I don't know how to do it so you all aren't seeing both of my screens. Elaine, do you know?
Okay, so go ahead and put it back up. Let's see if we can't troubleshoot it real quick.
All right. Actually, I think I figured it out.
Oh, I think I helped you do it.
You know, you probably did. Now let's see. What about now?
That is perfect.
Great. Okay. So this is going to be a little awkward. I'm going to look at a screen so I can see some of you on one side and I'm looking at my presentation on the other. So just bear with me if it looks like I'm not. Well, good afternoon. I'm really glad you guys are joining. I know it's late in the day, and so you've kind of sat through presentations already, but I appreciate this. Please feel free to ask me questions along the way. I'll do my best to answer them. I'm also going to leave some time at the end. If you raise your hand and it's up for a little while, feel free someone to interrupt me so I can stop and answer along the way.
Okay,
And
so Lauren, I'm going to stop you for a second. I
Okay.
just want to make sure that don't physically raise your hand because some of you don't have your video on and that is not going to work at all. If you look down at the bottom of your screen, there is a little thing. It's got a smiley face and a plus and his reactions. And if you click on that, you'll see that you'll be able to virtually raise your hand and it will jump you up to the top of the participant list. And then Lauren will know that you've got a question. Okay, so don't physically raise your hand. That is not going to help us at all. Okay, thanks.
Thank you for that. All right, so let's get started. Let me see. Okay, so we're going to go over some objectives, the content, a summary, and then, like I said, questions at the end. I did include an introduction, but Mia did that for me, so we can go ahead and skip that. All right, so during this time, you guys will be able to identify just basic eating disorder symptoms, hopefully identify common co-occurring, as well as identifying some screening tools that you'll use. if you think an eating disorder is suspected, as well as treatment options. Now, I know some of this might be repetitive from your other sessions, and I'm hoping that's the case because we definitely want to make sure that you guys are understanding of it, and the more repetition you have, the better, because you want it to be something that you are commonly assessing for when you're doing a clinical interview or an intake. And most people are uncomfortable with eating disorders because they don't know a lot about them. All right, and I am about to do this without notes, so you guys bear with me, and we are going to see how this goes. All right, so some general statistics, and hopefully you guys, again, throughout this day have identified how severe and important not only the diagnosis and detection of eating disorders, but what can happen. So at least 9% of the population worldwide suffers from eating disorders. That is pretty high in comparison. I think the anxiety and depression statistics are now about 20%. 9% of the US population will have an eating disorder in their lifetime. And that's pretty high as well when we think about how much treatment is out there for eating disorders. Less than 6% of people with eating disorders are medically diagnosed as underweight. And that statistic is really important. I want you guys to keep that one in mind, because eating disorders aren't just for those who are underweight. And there are also some ethical dilemmas about BMI and how that's constructed based on race. And so that kind of makes that percentage difficult to assess, because we know that eating disorders, those who are struggling with bulimia or binge eating, aren't often going to be diagnosed as underweight. 28 to 74% are at risk for eating disorders through genetic heritability. So we want to make sure that, and again, this will be something I talk about, that we are looking at the parents and families and seeing if anyone has an eating disorder, because a lot of times when someone has a parent that struggles with an eating disorder, they do as well. Eating disorders are among the deadliest mental illness, second only to opioid overdose. And that's for many reasons, not only with suicide attempts, but the medical complications that go along with eating disorders. I won't go into them specifically, just because that is not my forte. However, it can be significant malnourishment that leads to difficulties with your heart. You can have overall like difficulties with different labs that show up that impact different parts of your body that people don't often think about. Over 10,000 deaths each year are the direct result of an eating disorder. So that's about 1 every 52 minutes. So even thinking about how long you guys have sat in this training for the day, think about how many people that could have impacted. And then about 26% of people with an eating disorder attempt suicide. So those statistics are general. I wanted to include some about children and adolescents, since that's definitely our focus, is that 42% of first and third grade girls want to be thinner. So when you think about that, that's almost half. If you think about a classroom, that's almost half. At what is a first grader, like 7 or 8, up until maybe 9 or 10, that they're thinking about their body and what they look like instead of kind of just being kids and having fun. 81% of 10-year-olds are afraid of being fat. That's also pretty high. You think 10 years old is around the 4th grade, and a lot of them are focused on their body, what they look like. They can be comparing themselves to different people in their class, maybe if they're in a sport. I think it's really important to, and I'll talk about athletes, and not to say that you shouldn't engage in these, so please don't hear that, but people who might be in dance or any activity where they're looking at their bodies, they're looking in mirrors, often they can be comparing themselves to their peers, like, well, why does she look like this and why do I look like this? 46% of 9 to 11-year-olds are sometimes or very often on diets. So when we look at diets here, we're not talking about they're like keto or they're doing Weight Watchers or anything like that. But when we say diets, we mean in this sense that they are somehow manipulating what they're eating. So they may decide that they don't want to eat dessert, or maybe they only have cookies on this day, or maybe they decide that they don't want to eat fried foods and maybe they pick apples instead of fries. So we would consider that kind of a diet that's more relatable for a 9 to 11-year-old. 35 to 57% of adolescent girls engage in crash dieting, fasting, self-induced vomiting, diet pills, or laxatives. Just pretty high. I mean, that's 50%. You think about, again, a classroom or even a sports team, that it could be half of those people are engaging in that. And then finally, in a college campus survey, 91% of women attempted to control their weight through dieting. Again, that's pretty high. College culture, we know, promotes drinking, eating habits. I mean, most people in college aren't getting up and eating breakfast, lunch, and dinner and snacks during the day just because of their lifestyle. But in that, they're also saying, okay, well, I want to pay attention to how I look, or how I look matters. And so in that, I'm going to make sure I'm manipulating that. All right. Let me, okay, just making sure I don't have any hands. Okay, so again, these might be repetitive, but I still want to go over them. So the disorders are anorexia nervosa, which has 2 types, restrictive and binge purge, bulimia, binge eating, OSFED or other specified feeding and eating disorder, and then ARFID, which is avoidant restrictive food intake disorder. Okay. So anorexia, again, I'm not going to read the entire slide to you all, but we are really looking at restriction of food in some way. In some way, they're limiting the amount of calories that their body's getting. There is an intense fear of gaining weight or becoming fat, even though they're seen as underweight. So it could be someone who is, and I am just using numbers, and these are not at all, I don't want you to think anything about the number, just easy for me to say off the top of my head, to be honest. So it could be someone who weighs 120 pounds and see themselves as fat. And so they want to continue to lose weight. I actually just assessed someone about a week ago who she didn't want to have 3 numbers on the scale. So she was a teenager and her goal was to be under 3 numbers. So she wanted to be in the 90s. Now we know that, like, okay, maybe certain body types, that's acceptable, but she was also doing something to make sure that she stayed under 3 numbers, because she felt like when she was at, I think it was 104, that she was fat. And then their self-esteem, how they feel about themselves, their self-worth, all of that is really, really related to what their body looks like, their weight or their shape. And again, we know that, again, I'm just using 120, is very different on someone who's 5'10" versus someone who's 5 foot, right? And so numbers are arbitrary in that way. So again, looking at those, we want to look at the 2, now I guess, subtypes, you want to call them. So we have restrictive type and binge purge type. So restrictive type is really that they are restricting their food in some way. So I may have, and I'll probably use a lot of instances of people that I've worked with who decide, I'm not eating a certain amount of calories per day. So maybe they choose that they're only going to eat 1,000 calories a day, which is not sufficient for anyone. Or they decide, I am going to restrict a food group. So maybe they cut out all carbs. Maybe they cut out sweets. It's really common for people who are struggling with ANR to cut out fast food, greasy foods, foods that they see as unhealthy. What else? They could also cut out the times that they're eating, and that's kind of what people call intermittent fasting, but maybe they're only eating between a certain amount of hours. And then you have binge purge type, which again, they're still underweight, they're still restricting, but they're engaging in these times where they're eating a lot of food and then purging it. whenever they're engaging in any binges. Any questions so far? All right. Bulimia. So bulimia is very similar actually to AMBP, anorexia nervosa binge purge type. The difference is, and this is a major difference when you're diagnosing, is that those who are struggling with bulimia are not considered underweight. They are not, there is no, they might have what, quote unquote, a normal BMI. They're engaging in binges, which is when you're eating a certain amount of food in a certain amount of time. Typically with binges, I'll give you an example. I've had people who will get off work, they'll go maybe to a fast food place, get a meal, eat the meal. Maybe they stop by the store, grab some snacks, eat snacks on the way home, come home, and then eat a full dinner. So maybe in a span of like 2.5 hours, they've eaten that amount of food. And we would typically say that's larger than what most people eat. And they have no control over that eating. They just start and they feel like they can't stop. There are also people who binge at night or in the evening time, where they may go into the cabinets and they just eat whatever they see. And I don't mean binging is like, hey, I'm gonna go get 2 sandwiches from a restaurant, from a fast food place instead of 1. It's like food that, when in a subjective way, when you think about it, you're like, where do you put it? You know, like you're not feeling full, you're not, nothing is like telling you to stop, but the reality is they're eating past that point. They're ignoring what we call their fullness cue. It's like that thing that your brain sets off to say, hey, you've had enough. With the binge, they are doing something compensatory. So they're either vomiting, they're either using laxatives, other medications that they know will help them lose weight. They're fasting or excessive exercise. Excessive exercise is something to really pay attention when you guys are assessing adolescents, because athletes are often forgotten about when it comes to eating disorders, and they struggle with them as well. When you think about sports that have a weight cutoff or a weight limit, how are they like engaging in that? I think of wrestling as probably the most maybe guilty of those, because they have a weight class they have to stay in, and usually people will do stuff to make sure that they either gain the weight they need to get there or lose it to get there. You also have people that want to look a certain way when they're playing a sport because they feel like their performance is related in some way to that. So be very aware of that. I usually have cross-country athletes. I've seen a lot of those that it's a intense workout. You're burning a lot of calories and you're doing it consistently. And sometimes they are using that as a way to monitor their body based on how they eat. Just some time frames. So for the binge eating and compensatory behaviors, at least once a week for 3 months. Again, they're pretty self-conscious. And the binging and purging is not related to anorexia. So the difference here, again, is where their weight falls. Are they in a normal weight or are they underweight? And that's the big difference here. All right. So binge eating, I kind of described that with bulimia. Again, with binge eating, you're looking at them eating a large amount of food in a certain amount of time. They're pushing past full. They're eating food when they're not hungry, often alone. I have a lot of parents and spouses who don't even know that their partner or their kids are struggling with the eating disorder, because typically when people are binging, they're doing it when no one else is around. Their parents could be at work. They could be asleep. That's another thing. A lot of times, kids can be up and roaming the house and their parents are in their bed asleep, and that's when they go through and eat. And then sometimes parents only notice because maybe they're going to the grocery store more often than they should, or they're kind of questioning, well, who's eating this because I'm not seeing it. Often they hide their wrappers or hide food in their room so that no one, shows up downstairs and they're eating or questioning them about it. Something really important here is there's some level of like guilt, shame, embarrassment around the eating. They're not like proud to engage in these behaviors. A lot of shame there. And again, with diagnosing these are not, excuse me, related to anorexia or bulimia or ARFID. All right. So OSFED is this catch-all that we typically have where it's anything that really identifies that there's an eating disorder present, but it doesn't meet full criteria for anything else. And so that's a great question. So that's more under OSFED. Typically, people who are struggling with orthorexia are also struggling with some form of, I don't want to say some form of eating, but they're doing something to manage their eating as well. So typically that's not going to be like a primary diagnosis. It's going to be whatever the eating disorder is. And then most people will say like, and they're having like orthorexic tendencies with that. You can diagnose it with OSFED if you want, but I would pay attention to what are the other behaviors that you're working on as well. So is it restriction? Is it purging? Is it binging? Any of those? I hope I answered that. So let me, all right. So in OSFED, just think of it with any of your like depression, anxiety, when you have that like NOS or unspecified, it's kind of the catch-all, because you really say you have someone who is, I can use bulimic, for example. Well, they're showing behaviors, but maybe it's not been present for 3 months. And you still want to alert someone that, hey, like this is going on, this is a concern, this is what we're treatment planning around, but it may not meet full criteria. So these atypical anorexia, bulimia, binge eating, purging, and night eating. Night eating is pretty self-explanatory. So is purging. A lot of these is the time frame around them doesn't meet full criteria. You really want to, and I diagnose OSFED a lot, to be honest. I had someone the other day that was engaging in behaviors that she had previously been diagnosed bulimic. However, she had began to restrict within the last year. And so it looked like, okay, maybe this person is struggling with anorexia, binge, purge, but her behaviors weren't what I would classify as a binge, because she wasn't eating. Her idea of a binge was eating 2 breakfast sandwiches for breakfast. And that's a pretty normalized amount of food, especially because she would restrict after 3 p.m. So after 3, she wouldn't eat anything else. So I'm thinking, well, you're probably also eating 2 breakfast sandwiches in the morning because you're hungry. Your body's making up for that calorie loss, not necessarily that it's a binge. So she's someone who I would probably diagnose OSFED right now, because she's kind of shifted behaviors. It's not bulimia like it used to be, because she's not engaging all the way in those, but it doesn't quite feel like anorexia either. All right, so ARFID. I don't know how many people are familiar with this. ARFID is pretty new. Not a lot of people know how to treat ARFID. I've had people from different states struggle to find providers that know what to do with it, how to help it. It's pretty significant. So I like to think of ARFID more as a feeding disorder, not so much the eating. So most of the time when people are struggling with eating, they're struggling with, what is the food doing once it's in my body, excuse me. So when it's in my body, then it's going to make me fat, or it's going to make me whatever the idea is. Whereas ARFID, it's the actual like feeding process that's a struggle. And so with them avoiding certain things, they typically have significant weight loss. They have nutritional deficiencies because they're not getting everything that they need. They could be dependent on feedings, or maybe they have to take Ensure or other supplements, and it's interfering with them, with their psychosocial functioning. Really important to identify is that ARFID, anyone struggling with ARFID does not have any body image distress. So if there's ever any body image distress, you know it's not ARFID. So to give you an example, I've had, I can give you a kid example. One, probably like 11 years old, who would only eat about 5 different foods. And so in this, those 5 foods may have been like chicken nuggets, but it's not that they can eat chicken nuggets from Chick-fil-A. They can go to a restaurant and eat chicken nuggets. It's that they only eat the Tyson chicken nuggets that are shaped like dinosaurs. Or if they eat macaroni and cheese, maybe they're only eating the Kraft macaroni and cheese. They won't eat other kinds. So it's very specific. They may, so let's say they eat chicken nuggets, they might eat toast, they might eat macaroni and cheese. Maybe they eat a fruit, but it's very, very limited. And it's the intake. And this might be caused from a few things. One of those things might be trauma. Maybe they were younger and they choked on something, or they threw up, or they just had some form of an adverse reaction. And then their brain has connected this idea of like, you can't eat that because that's not safe. And then they start cutting out food. I had an adult that I don't remember exactly how many things he ate. It was a few years ago, but he was having health issues as I think he was like 47. And he had all these deficiencies, all these health issues, high blood pressure, cholesterol, but he ate no fruits and vegetables at all. He would only eat American food. And that's kind of how he described it, which meant he was only eating burgers and fries. He would eat fast food. He would eat steak, but he wouldn't eat anything else. And he would eat potatoes. So his body, obviously, after like 20 years of doing that, is going to start reacting. You may have weight loss, other deficiencies that are just impacting him. He wouldn't go out to eat because he would only eat these certain things. And so part of the treatment for ARFID is actually behavioral. It's what we call food discoveries. A lot of the work you're doing is focusing on their body sensations. So how are they feeling? Where are they feeling it? And kind of working on regulating that so that when they eat, it doesn't feel, they're able to manage the anxiety that they feel when they're eating. We also do a food hierarchy. So we're listing a bunch of foods and rating them in distress. And then we introduce them slowly and we put them on this like egg plate. And with the plate, we don't just say, hey, we want you to try 5 new foods this week, because that's typically not going to happen. But based on what they say in the hierarchy, we're saying, okay, I remember I had a kid and he would not eat grapes. And so it took us like 3 weeks to get him to just taste a grape. And we took it slowly. So it might mean that the grape just sits on his plate. And he might have so much distress that he can't eat it. Then he might get to the point where he like licks it. And that's all that he does. Or moves it around in his hand. And then he gets to the point where he can lick it. Or then he might bite it, but he might not eat it. And then he might chew it and he might spit it out and not swallow it. And so it's a pretty slow process. It's pretty intense treatment, but it's really behavioral based. They're not struggling with how their body looks. With kids, it's pretty difficult though, because a majority of them have impacted or stunted their growth because they're not eating and usually have to supplement so they can get what they need. All right, any questions before I move on? All right. So co-occurring disorders, 94% of those suffering with the eating disorder are also diagnosed with a mental health disorder. I don't think actually have ever worked with someone who didn't have another diagnosis as well as an eating disorder. The first set that we're going to look at is just depression. So if you look at this graphic, 92% of the people who are hospitalized for eating disorder also struggle with depression. It's higher for those with anorexia, and then bulimia and binge eating are pretty close. A lot of times, and this is similar with anxiety disorders as well, and some substance abuse, is they're coping. They choose to cope through the control of eating, or they feel like they don't have any other coping skill. And so let me begin to do different things with my food. And sometimes it's seen as a punishment, like I'm going to restrict myself because I'm also punishing myself. All right, anxiety disorder. So this is kind of the opposite. Binge eating and bulimia are higher than anorexia. Again, most of the clients that I see have depression as a co-occurring or anxiety. In the anxiety disorders, it covers a variety. The clients are also usually anxious, like food. I'm not going to say it causes it, but there's a direct relation. They might experience a lot of distress around eating. Eating is typically taking all of their thoughts. I had someone tell me a few months ago that like food, so whether it be what I'm going to eat, what I don't want to eat, what I'm going to eat tomorrow, any of those things is always on their mind. They don't have time to think about other things because they're just thinking about food all the time. And some other disorders that I know you guys talked about, trauma, so I don't want to get into that, but also OCD, borderline personality, and some other characteristics are pretty common. Something I want you guys to keep in mind really is the personality characteristics. A lot, I would say probably as high as 90%, of the people, adolescents I've seen that struggle with anorexia are high achieving. So they're like top 5, 10 of their class. They're perfectionist. Their parents describe them as perfectionists. They're rigid in their thinking. They might be super organized. They're like, quote unquote, this model kid, and they develop an eating disorder. And a lot of the parents are shocked by this. A lot of them struggle, honestly, with getting them the appropriate treatment because school is so important to them that they want to make sure they don't miss school. They get into these great colleges. And a lot of times I really explain to parents that eating disorders don't go away. It's not something that goes away without intervention. And you don't want your kid to go to college and then struggle with something like this. And the longer that you go without treating them, the harder it is to get them through recovery. And so it's really important. And I understand taking a kid out of school feels like the end of the world to a kid who has like a 4.3 and is like 3rd or 4th in their class. And when you're struggling with an eating disorder, you're also not functioning to your highest capabilities cognitively. Your memory is impacted, your concentration is impacted because your body is compensating. It's not being fed how it's supposed to. And so you're naturally going to have these things that most people don't think about or identify. With OCD, it's more the behavioral thing. So we see a lot of some behaviors maybe for anorexia is like they're cutting their food up in super small pieces. So maybe this person is counting how many times they cut their food, counting how many times they chew, the size of the portions that they have. So it's really based on their plate. And some of those behaviors, we do identify, hey, they might have some OCD coming up, and making sure they have someone that can work with those, because it could be that they are struggling with both. It doesn't have to be either or. And then with borderline, we know that's related to trauma and PTSD, but also just a lack of a sense of self. And with an eating disorder, it's really hard to have a sense of self, and it fluctuates just like those struggling with BPD. And substance use, 50% of people with eating disorders struggle with substance use. Again, substance and eating are very similar in that there is this idea of like long-term recovery, or that I hear people say a lot of times, I'm been in recovery for an eating disorder for 20 years, meaning I'm doing okay now, but it's still something that comes up for me, or it's something that I haven't engaged in a behavior in this amount of time, but I'm always aware, or that I'm making sure that I stay in recovery and I don't relapse. A lot of the words we use in eating disorder treatment are very similar to those in substance use. Similar with like substance use, you want to get the family involved and make sure they have a community of support, just like with eating disorders. All right, do I have any questions before I kind of move on to screening? All right. So we're going to look at 3 different screening tools that you can use for eating disorders. Again, the second one is just really for primary care, and they're really important in the eating disorder, the diagnosis of eating disorders, and I'll kind of get into that. The first one is the EDEQ. I actually more so depend on the clinical interview. I rarely use the EDEQ. I actually don't think I've ever used it clinically, and I don't really train people to use it for a few reasons. I think it's, and I'll pull it up and we can go through it. It's really useful in identifying some of the things that's difficult, is that it looks at behaviors within the last 28 days. And we know that a lot of the behaviors, in order to diagnose, we've got to have 3 months. And so if you're asking 28 days, you may not get an accurate diagnosis. But it definitely helps you to be able to identify what the actual behaviors are. And so I am going to, can you all see this, the screen? I can probably make it bigger. I hope I can. Can you all see it though?
Yeah,
Okay.
we can see it. You can actually make it bigger at the top where it says 100 and just hit the plus.
I don't
At the top of your screen where it says 100%, it's a plus sign.
and I don't even see
In
100.
that, it's right above the questionnaire in that little black bar.
Yep, the
Move
little
your-
plus.
There you
Oh,
go.
Right there.
something was covering it. Is that better? Okay, let's not go 250.
I've
I'm glad
also-
you guys said that, because I
There you
probably
go.
wouldn't have been able to read it if I was on your end either. All right, so this is the questionnaire that you can use. I think it's about 30 questions. And again, just pay attention to the fact that it only looks at behaviors within the past 4 weeks. So the first set of questions, it's asking more so behaviors that we would consider restriction. And so it kind of would help you to identify any anorexia. And then it's asking how many days, which is helpful if you're trying to figure out how often they're engaging in those. So just a few: deliberately trying to limit your food. Have you gone long periods of time without eating? Have you tried to exclude from your diet any food? So this is kind of like if people are starting to maybe limit dessert, maybe limit carbs or fast food. Following any rules. So maybe they're saying, hey, I can only eat, I don't know, 1,200 calories a day. Or maybe saying I can't eat after a certain amount of time. These questions are asking about an empty stomach with the aim of influencing your shape or weight. So we know that would help us determine if they're doing anything purging wise. Has thinking about food made it very difficult to concentrate on things? Has thinking, that's like a similar, one is weight or shape, one is calories. And so you can kind of see, and I'll show you at the end of this, how the measures differ. But again, this is more so just giving you information as to what they're struggling with. loss of control, fear of weight gain, have you felt fat? Then the second part, again, keep in mind, these are just the past 4 weeks, and you're filling in the number. How many times have you eaten with other people? Or sorry, what other people would regard as unusually large amount? We know that's going to gauge binging. I don't want to go through every single one. How many days have you had these episodes of overeating? How many times have you made yourself sick, taken laxatives, engaged in exercise in a driven or compulsive way? I also feel like some of these questions, again, are standard to kind of help you get comfortable with assessing, but you're going to have to reword some of this if you're giving it to a kid, because most kids are not going to identify exercise as driven or compulsive. Most adults actually don't. When I ask them about it, they're like, no, like that's completely normal. I have a 15-year-old that I see that exercises 5 to 7 days a week, which we would say, okay, like that's nothing wrong with that. But she exercises to the point where it's hard for her to walk up steps because her legs are so sore. And so we would say that that's pretty, I would say over the top. It's pretty driven, because that's not normative to work out. Yes, we might work out to the point you're sore, but not to the point where you're like holding on to the sides to get up the steps because you've done so much intense workout with your legs. And these, again, questions that are asking, giving you time frames of like how often, and so these are binge eating, so eating in secret, and you can give examples, you know, if you eat in your car and no one knows, or eating in your room, felt guilty, and been concerned about other people seeing you eat. So this last set of questions, more so talking about yourself, how you feel about your body. It's a rating scale. And so given their weight and height is going to be beneficial more so if you're working in a team where a dietitian or a doctor is kind of giving you that, because you guys as clinicians won't really have an idea of like what's appropriate given their age, weight and height. That's nothing I ever look at. One thing really important to look at is menstrual cycles. You want to make sure that their cycles haven't been impacted. Typically, adolescents don't have super normal cycles anyway, but if they're underweight, their cycle is going to be impacted. That's one of an indicator for us that people are struggling with an eating disorder. When their cycles are irregular, they're not on birth control, because those are one of the things that your body decides that it gives up. You know, there's so many things that are taxing on your body's energy, and it just decides that a cycle isn't necessary. Then if you go down here, and again, I don't really use this. I've used it, or I've looked at it to kind of gauge different behaviors, but I don't typically use it, but it can help you to identify, okay, where should people land when it comes to certain numbers? And you have to use your clinical judgment like anything else, you guys know. And again, this is adults. You can still use it with kids. I would reword certain things and change the time frames, but I did want to give you guys something to use. And then, of course, the higher your scores are, the higher your symptomology is. All right, you guys can see my screen? Perfect. All right, primary care. So any doctor that or pediatrician that you're looking at, again, this is very, very brief. Literally 5 questions, yes or no. Are you satisfied with your eating patterns? Do you ever eat in secret? Your weight affect the way you feel? Any members of your family suffer with an eating disorder? Do you currently suffer? I don't think it's great, but I think it is a step, because a lot of people don't screen for eating disorders for a few reasons. I mean, especially if the kid is in like a normal, what they would classify as a normal BMI, they're typically not going to ask. And we know that you can have a normal BMI and still struggle with an eating disorder. And we want parents to be really involved. And typically we're only taking our kid to the doctor, if they're not feeling well. Not a lot of people even take their kid in for their yearly checkups, and they don't just take your height and weight all the time. And so if they're not doing that, you really wouldn't know if they're not on their growth curve or if anything is happening until there starts to be a decline. My favorite, obviously, because I'm a clinician, is a clinical interview. And just gauging these behaviors. So if it's restriction, you want to be able to identify, like, hey, have they ever engaged in times that they aren't eating a certain food, or that they are limiting themselves? I typically don't really use the eating disorder words if I'm working with an adolescent, because they may not. Typically, they're only thinking about is vomiting. And they're like, oh, I don't vomit. And that doesn't mean you're not struggling with eating disorder. Binging, thinking about just how much, when they are saying they binge, which some people say yes, it's really good to figure out how much. Like, so tell me in a typical binge how much you're eating. And then you can gauge using your clinical judgment, okay, that's a little bit more than one would need to kind of feel full. Compensatory behaviors, again, you're looking at vomiting, you're looking at exercise, you are looking at laxative use. I have had people, certain medications, maybe for ADHD, and again, I don't want to get into specifics because this is not my lane, but ADHD, depression meds that they know impact their appetites, sometimes they will use those to impact their weight as well, and not necessarily be taking what we would consider diuretic or laxative. Food aversion. So if you notice someone has some picky eating going on, and a little bit extreme than picky eating. Like, I wouldn't say, my 3-year-old who chooses to eat chicken nuggets, macaroni and cheese, and fruit all day struggles with an eating disorder. Like, because that's normative for kids at a certain age to eat certain things. I wouldn't expect her to sit and eat Brussels sprouts. I don't expect her to eat certain foods, but just keeping an eye on that, and even their openness to try new foods. And then, of course, weight changes. You want to assess from the parents, because kids, depending on how old they are, won't know. But like, have you noticed like their clothes looking any differently on them? Or are you buying clothes because maybe they're gaining weight or maybe they're losing weight? Because at no point, and please keep this in mind, should kids ever lose weight. There should be no reason, because they should be on their growth curve. And as they're getting taller, they should typically be gaining weight. And so if a kid at like 10 or 11 is losing weight, we want to figure out why. It's not an eating disorder. We also want to make sure medically what's going on. Because even if, let's say someone said, hey, maybe you're overweight, and we want to look at you eating better, that's also concerning, because we don't want that to turn into an eating disorder because someone has told them that they are this size. I also tell parents, we typically take kids to Patient First, like KidMed or any of those urgent cares, and they give you a printout with the BMI. Be careful about sharing that information with your kid, because a lot of times, again, that's a very biased way of looking at weight, and most of the time it's going to say they're overweight or obese. And if a 13-year-old sees something that says they're obese, typically they're going to care, just like any adult would when you see it and it's like, oh, I'm overweight, like I need to do something about that. All right, so I've talked about all of these, but I do want to just give you a list. So some warning signs or symptoms that you should be looking out for. And even when you're meeting with the parents, looking out to see if they've seen any of these behaviors or signs, sorry. So discussion of food, discussion of dieting or weight loss, like that's not anything a kid should be talking about. Preoccupation with food. So maybe they're like starting to measure their food, or they're starting to ask about stuff that you put in their food, because they could be trying to figure out how many calories You know, if you're adding butter or you're adding oil, they want to know what's going on. If they are refusing to eat certain foods. So please identify if like an adolescent or kid is like requesting a salad. That's concerning. Maybe every once in a while, everyone, you know, that's fine, but they shouldn't just be, if they're at lunch at school, they shouldn't be just getting a salad every day for lunch. Or they shouldn't be, they should eat normal food. Like it's okay for a kid to want to have pizza and want to have a burger or want to have cake or cupcakes or something like that. I'm not saying you have to eat it every day, all day. And if they did, that's okay too. But we want to make sure that it's like normalized eating. One thing to keep in mind here, and this is kind of related to parents, is that idea of healthy eating versus unhealthy eating. You know, you don't want your kids that you're saying to eat like 100-calorie snacks all the time, right? Like just the idea of like limiting that, and they pick up on things. If they have any rituals around food, maybe they cut up their food a lot. Parents see that they're like taking a long time to chew their food, taking really small bites, because that helps us get full quicker. Skipping meals. So this is hard sometimes with adolescents because typically they don't always eat breakfast. And so we want to pay attention to if you notice any meals being skipped or smaller portions, any dieting, not eating around people, and just worried about how they look a lot more. If they're body checking, which is standing in the mirror and kind of looking at themselves a lot. I mean, we all look in mirrors, but we want to make sure that they're not kind of nitpicking at certain things. And then mood swings. All right, physical. So again, I'm not going to go into all of these, excuse me, because I work usually in a team, and so I don't identify all of these, but if there are any fluctuations in your weight, you want, even you can notice something like this, or the parents, if they're complaining of anything, gastro going on, again, looking at their cycle, if there are any irregularities. And some people are going to say, hey, they started their cycle a year ago and they've never been regular. But if they've been struggling with an eating disorder since they started, then that could be impacting that. Any difficulties concentrating, any lab abnormalities, any dizziness. So when people are restricting significantly, they're going to have changes in their vitals when they go from sitting to standing. So if a kid is like complaining of that, that's definitely something to be aware of. Fading or syncope, feeling cold, trouble with sleep, cuts and calluses aren't super common because people learn how to work the system with that, and that's pretty intense. So I wouldn't say that's going to come up often, but be aware. If parents identify any dental problems, there are often changes in your hair, your skin, and just feeling weak or getting sick a lot. All these things that hopefully a primary care is aware of, but a lot of pediatricians are not versed in eating disorders, to be very honest with you. All right. So early intervention, regular medical checkups with your pediatrician are really, really important. They're going to be able to identify the physical symptoms typically before anybody else is. Eating disorders in kids stunt growth. If they fall off of their growth curves, it is typically hard to get them back on. And that's stunting their growth is something we can't get back. And it's kind of at their prime of growing. And so we want to make sure that we do what we can. It's actually a major goal of eating disorder treatment. It's a team effort. So you want to have a medical provider, a dietitian, as well as a therapist that's working in tandem. You should not work as a therapist with eating disorders without the person having a dietitian. That is really important because you are not going to be able to work with you don't know how much they need. For one, like the calories, I don't know. I can guess it sometimes, but you want someone who knows how many calories they need in order to gain a certain amount of weight. You want to know them to make sure they can identify what labs are needed to make sure that they're functioning, how they can kind of get creative in providing a meal plan. Identify parent risk factors. So just making sure that I don't really ask a kid, hey, like, is your parent struggling with an eating disorder? Because, because if they are struggling with an eating, or the kids may not know, but how many times do people go to the doctor and actually get diagnosed with an eating disorder? I typically ask, hey, like, have you noticed any changes with your parents eating? Or you notice any behaviors that may not be diagnosed, but just are interesting with the way they think about food or think about themselves? And obviously always inquire about eating patterns. Great question. So ethically, you really should suggest a dietitian, and having kind of like a list of those. Some of them work exclusively with eating disorders, some don't. I try not to get too into the nutrition part if they don't have a dietitian. And sometimes, like, I work with people in outpatient, I see them every other week, and they're not engaging in behaviors to the point where I'm like, okay, I notice any weight changes, but I may assess that they're eating 3 meals and 2 snacks a day. And if I notice that that's getting low, then we need to use some skills to try to increase that. And if not, they have to get a dietitian. I can also require blind weights, which really should be a dietitian, but I'm not going to do anything medically, so I'm not kind of stepping on anyone else's toes. And I may ask the parent, hey, I need them weighed every Sunday night. And so the kid doesn't know the weight, parents only know, and they email it to me. And then if I notice there's some dips in weight or changes, or they're not increasing or not, really they should be stable in outpatient, then I'm definitely going to say, hey, I need you to see somebody, so we can monitor this. I often tell, for Medicaid, I often tell them to ask their case manager, should have some that help. To be honest, it is really hard in the eating disorder world to find people who take insurance, let alone Medicaid. And that's just kind of like a sucky part of the system, to be very honest with you. And so I have a few that I know take insurance, but Medicaid is definitely difficult. Sometimes I'll also have them communicate with their primary care to see if they can monitor weights and labs. And we kind of tag team it that way, so I know that they're getting eyes medically. All right, so levels of care. I wanted to kind of go over this so you guys are aware. The flow of this is gonna sound, it's backwards to me, but I think it's gonna make sense to you all. So outpatient is the lowest level of care, and I put that first because that's where most of you, I'm assuming, are working or have that knowledge base. And then as you go through this, you go to higher level of care. However, eating disorder care is always treated at the highest level of care possible, the highest level that makes sense, and then you work your way down. So with let's say you start at partial hospitalization, when you finish that, you go to intensive outpatient, and then you go outpatient. A lot of times we explain this to parents and patients that if someone told you you had cancer, you wouldn't ask, what's the least amount I can do to become better? You would say, what's the most intense so I know that it doesn't come back? And so that's how eating disorder treatment is as well. So the first one's outpatient. Again, I've kind of already described this. You want to work best practices therapists and an RD. I know that's not always ideal. You want to have the pediatrician involved to some degree just to make sure somebody's watching. Labs may be monthly. And at this level of care, they're in their normal life. They're still going to work. They're still going to school. They're still engaging. What we're doing is just making sure that we're kind of monitoring, identifying skills they can use when they're experiencing urges, which is like when they want to engage in behavior. And then DBT and FBT are evidence-based approaches that are often used. You can use CBT as well. DBT because it's skill-based, and you're teaching them skills to use when they're having the urges. And FBT is family-based treatment. And so that is having the family involved, the family's cooking meals, the family's in the kitchen, and the family is teaching or supporting the kid in their meal completion, because that's really the goal, is we want to teach them how to eat again. And again, this is lowest level. You go one step higher and you have IOP and PHP. So IOP is typically about 3 hours a week. 3 hours a day, 3 to 4 times per week. You meet with your RD and your therapist. IOP is more intense. They're still stable medically in their weight, but you're working on maybe some increased skills. Maybe they feel like they need more support than just a therapist weekly. They need more support around maybe dinner time. That's typically when they have programming. But remember, this is kind of also looking at step down. So when they step down from IOP, they would then go to outpatient, which is less treatment. Then you have partial hospitalization, which is 5 to 6 days per week. Typically about 7 to 8 hours per day. A lot of people, well, I'm not going to say a lot, people offer it virtually now since the pandemic. You typically meet with the RD, a therapist, med provider, and a psych provider. Here, it may require some level of weight restoration. And so, I actually didn't talk about this. When anyone comes in for eating disorder treatment at a higher level of care, we're going to have what's called an EBW, an estimated body weight, that the dietitian is going to identify. And so with that EBW, we kind of look at and say, hey, how close are they? If I have a kid who is 90 pounds and their EBW is 120 to 130, then what is that, 25 pounds? Maybe to get there, that's a lot of weight. No, it's actually 35. That's a lot of weight for them to be able to put on in a PHP program. And so we would probably recommend residential. But we are definitely looking at how much they need to gain to get back on their growth curve, because that's kind of like the optimal space for them. And if we can't get them there onto their growth curve, we want to get them as close as we can. Here in PHP, they may have some minor medical concerns. So maybe some of their labs are abnormal. Maybe their vitals, there's some concern, but something that can be handled in an PHP is still considered outpatient because it's not an inpatient level of care. So it doesn't require a nurse 24/7, but we're definitely seeing some instability. And we're still looking to decrease urges and increase skill use. And the most intense, which everyone typically freaks out about because it is a huge disruptor, and often a struggle why people don't get treatment. And for Sarah, this probably, when you ask about Medicaid, a lot of facilities do not accept Medicaid at higher levels of care. Again, that's like a systematic thing, and it's really, really difficult to find ones that do. But residential is when there's medical instability. So maybe their vitals are concerning. They need 24/7 medical care. They'll be seen by a doctor a certain amount of times a week. There's nurses always there. They live there, obviously. Excuse me. And most of the time, there's a lack of awareness of the eating disorder behavior. So maybe they're engaging and they don't see it as an eating disorder. They're malnourished often. They have an inability to engage in life without behavior use. So they're purging. I have a client who I'm like trialing her at a lower level of care, but she was purging like 2 to 3 times a day, 5 to 7 days per week for like 20 years. And her body had kind of adjusted, I guess, to the behaviors. I mean, none of her labs were, they were concerning, but it was just like nutritional deficiencies that you can just be given a supplement for. But within the last 2 weeks, she's been able to abstain from behaviors. I think she's gained like 7 pounds in 2 weeks, which is really, really good. But that's not something we typically want people to do at home because you can be at risk for refeeding. It's kind of like where your body has this like shock from like going from not eating to eating. All of a sudden, she did it prior to coming to see us. But residential is really, really difficult. They may have 20 pounds to gain, they may have 40 pounds to gain. And if you guys can imagine gaining 20 pounds at home, not easy. It's not easy when you've gone from eating 800-900 calories a day and then somebody's asking you to eat 3,500 in a day. Most people don't even know, like when you think about 3,500, it's like, wow, like I've seen people's plates that are on 4,000 calories a day because they're still in a weight restoration space. They're like, we can't do that safely at home. We want to do that in a space that is controlled and that they're supported, because that is really, really hard. And they're going to go through discomfort. I mean, you guys can imagine what it's like to go from not eating something to stretching your stomach. And that's what it is. Like your body has to adjust to eating that much. And again, typically at residential, they have some cognitive difficulties just because their body is malnourished. And that's some of the first things to go, because your body goes into survival mode. You're dehydrated. Your body, I mean, even group work, which is the kind of like the go-to for eating disorder treatment, partial hospitalization, IOP, residential, are all based on group work. We know that they're not even fully able to engage in groups as much as they need to because they're malnourished. All right. And then I just listed some specific options. Now, again, outpatient care, I just listed a few in the area that have some providers that take, that have eating disorder experience. And some people will have their CEDS, which is their certified eating disorders. It's like the certification. Some people are like supervisors. You can be CEDS as an RD as well. And the higher level of care, those are just some in the area. Veritas right now, we're pausing programming, but we typically have IOP and PHP here. We have residential in North Carolina, in Raleigh for adolescents, and actually Center for Discovery, I think it's in McLean, somewhere in Northern Virginia, that also does it. So typically I say, like, I mean, Northern Virginia, depending on where you are in this area, is 2 hours away. And so it's Raleigh. So it's not that big of a difference depending on where they are in Virginia. But unfortunately, eating disorders, like I said in the beginning, are undertreated. They aren't diagnosed well, and there's not a lot of people to work with them. I kind of left off minorities and working with like BIPOC communities or anything like that. But that's even harder because typically eating disorders create a lot of shame, a lot of guilt. I've had people with like 3 and 4 diagnoses, and eating disorders, they're hardest to talk about because they're most vulnerable. And to then find a provider who maybe isn't, I don't want to say not culturally responsive, but maybe doesn't understand culturally that eating disorders look different among different people, and they're typically a affluent young Caucasian female disorder, and that's just not true anymore. And that kind of leads to not having diagnosis the way as appropriate as it should be. All right, so I just had a quick summary of what we chatted about. So the eating disorders are common. Symptoms vary based on they have varying eating behaviors. So we talked about restriction, binging, compensatory behaviors, some food aversions. We talked about co-occurring disorders such as mood, anxiety, personality, and substance, some screening tools and services. And I did that whole thing without any notes. I am very proud of myself, guys. So I'm gonna stop sharing for a second and see if anyone has questions. I love questions. Even if it's about people I've seen, situations, anything. I know you guys are probably ready to go. Can it be seasonal? Yeah, I mean, I think we always look out in the fall, winter time for people to have an increase in mental health symptoms. It's also very interesting too, in the summertime, because people are wearing less clothing that they're impacted by eating disorders, or their body image distress increases because in the wintertime you can cover up. But it's weird if it's 85, 90 degrees and you're walking around in a hoodie. And that's also something you can talk to parents about. It's like, if you notice it's like real hot outside and they have a lot of clothes on, just kind of like with self-harm, you would kind of monitor for that. Also with body image, because a lot of them don't want to wear shorts. They don't want to wear anything, crop tops are in now, and it's like the least amount of skin, the better in the summertime. And so that can cause a lot of people who struggle with body image to be impacted. Any other questions? You guys are probably ready to go, and I talk the entire time. Anyone?
Well, I'm not ready to go. So we can hang out and talk until 4:30, 5 o'clock while everyone else sleeps. Thank you so much, Dr. Magruder. I appreciate your work and just your presentation, your research, and your effort for today. So I guess we're at the point where we are finished. Okay. Well, thank y'all, and enjoy the rest of your day and your week.